Test, test. Oh, very good. Good microphone, check. Yeah. Okay, good morning, everyone. We'll get you to take your seats. What's that? Can't hear me? Now I can, okay. I'm too tall. There we go. All right. So, can you hear me okay in the back? Good, okay. Welcome. I'm not Janice Pasica. She's a lot fitter than I am and commands a room better than I do, but she does send her regrets. Quite appropriately, she had a sore throat a couple of days ago and just could not kind of expose the rest of us to a potential cold and then not in the hospital, and we all know the ripple effect. So anyway, she wishes she was here, and she will be piped in later on during her presentation. So welcome, everyone. Here we are in person, 2022. Big breath in and out. I'm sure there's lots of stories about adventures trying to get here with planes, trains, and automobiles. I heard some interesting stories last night, but as we said, it's not a reflection of Quebec City. It's a reflection of post-pandemic, so let's remember that. So we have a really exciting agenda, and but first, I'd like to have the following people stand up. Jurish, Jackie, Enrico, and where is Radika? Where's she here? Oh, she's getting breakfast, okay. So we have to thank these individuals. Oh, there she is. Here she comes. Here's Radika. Okay, we're just thanking everyone for their effort in putting together this scientific agenda. And we appreciate your hard work. It started many months ago, and I really like the format. As you can see, we're doing a what's new format as well as case presentations, and we want this to be very interactive. So thank you to the group. We can give them a round of applause. And of course, we need to acknowledge our sponsors. So we have gold sponsors in AAA, Advanced Accelerator applications, in Ipsen, silver, Novartis, Point Biopharm, and bronze, Pfizer, and Raise Bio. So thank you very much to our sponsors. Big round of applause. So over the next few minutes, we're going to have two presentations. We're going to have a patient presentation with Simon, and thank you for coming. And then we'll have Dr. Shaw speak about the CNET's research grants overview. And then we'll move on to the first case presentation and presentation by Dr. Julie Halley. So we'll move on to the patient perspective. Great.
Okay. Good morning. So my name is Simon. Thank you all for your presence today. I'm 37 and I am a patient. I wrote a text about my journey, and when writing my text, I've tried to highlight what I've learned from it, and I'm really glad to be able to share it with you. On August 2017, my wife gave birth to our second child in the hospital. I was exhausted and vomiting in the restroom. Not exactly what a father should be doing during the labor of his wife. For several years before my diagnosis, I saw many doctors for sporadic gastrointestinal issues such as pain, vomiting, and fatigue. Most doctors were assuming that stress was the root cause of my condition. Other thoughts I had simply caught a virus from my kids' daycare. I even remember a gastroenterologist suggesting that I eat more fibers and probiotic foods and I should be fine. However, 2 weeks before Christmas 2017, my stomach pain was so intense that I decided to go to the emergency room at the closest at the closest hospital of my home. After finding a mass they thought to be a pancreatic cyst, they decided to operate on me. It turned out to be a major surgery in which I had many complications. That was my first Christmas being a dad of two little girls. I was discharged exactly on January 1st, 2018, as if a new era of my life was starting. It was only after 3 weeks of waiting, thanks to the Christmas backlog, that the pathology report came out with the proper diagnosis, a pancreatic neuroendocrine tumor. Sadly, for most of us, patients, we get the diagnosis way too late. In my case, I estimate 7 years between my first consultation for shoulder pain, since the tumor was irritating my nephric nerve, and my pathology report. In the last 5 years, I had my share of treatments. During my first surgery, a laparotomy, we did subtotal distal pancreatectomy, partial gastrectomy, and partial colectomy. 6 months after, we did a redo of the subtotal pancreatectomy, cholecystectomy, and a liver wedge. I did captain chemotherapy for months and a thermal ablation few months after. I did a third laparotomy in which we did a redo of the partial gastrectomy and additional lymph node removal. Finally, I did a liver blend embolization and recently a second thermal ablation. Because of my young age, on the exact same morning that I was told by my oncologist to start a captain chemotherapy, I left one hospital to go to the fertility clinic in another hospital to ask for a on-the-spot appointment. Happily, the team at the fertility clinic was very supportive of the process, and they did their best to not delay my chemotherapy treatment. Both hospitals are located only 700 meters from each other on the same street. I felt like it was a battle between life and death, and both were close to each other. To tell you the truth, seeing people my age starting a family without much care in the world, seeing former colleagues getting promotions, seeing friends taking new challenge, and planning their life in decades, not months, was challenging. Establishing yourself in a profession and starting a family is already challenging enough by itself. I feel that everything is a whole new ball game by adding the disease, the treatment, and the uncertainty. There's a common saying that we need to find the good in bad situations. In some cases, it's more difficult than in others. I had my diagnostic for close to 5 years now, and I believe that I'm just starting to be able to see some good in my journey. Did we lose the mic? No, it's fine, okay. Since my diagnosis, my wife and I decided to have a third child. Also, I wrote a story. This was my very first book, and I choose to address the difficult topic of mourning lived by children. I hope it will somehow provide comfort to my kids when the inevitable comes. In between all my treatments, I managed to become an Ironman 70.3 finishers. Prior to my disease, I did not know how deep inside you need to go to find the energy to push out your body in such challenge. You'll be surprised by how many cancer survivors and people who did not have it easy are on the starting lines of Ironman. My wife and I decided to take the step to build our dream house. I will never know if I will have done those things without having survived so much. But what I've noticed is that people make real and lasting change when they feel that they are at their lowest point. In my opinion, this is one of the biggest paradoxes in life. It's only when people reach rock bottom that they are able to brace up and to bounce back to something different and to something better. Most of us grew up being told that the only good reason to miss school is to go to the doctor. What's more important than your health? However, when going to the doctor starts to take up so much space in your life, it's easy to forget all the rest. Many patients on cancer treatments quit doing almost everything. So when treatment ends, patient enter a state of mind filled with many questions such as, what I'm supposed to do now? Indeed, I know that the vast majority of us cancer patients are not my age. I'm not suggesting that your patients should all run an Ironman or have a new child. However, patients can do things like no other people can do. They can find a perfect stranger to help, call a lost friend, having a hard time, be there for someone, make someone laugh, or build new true friendship. Even in dark moments, people can laugh and people can make friends. During war, prisoners of war camps are somehow finding a way to laugh and to daydream with each other. Humans just being humans. With the benefit of retrospect, I believe that there's good and bad situations. The good is that cancer survivors are different. If you are lucky enough to be different, walk away from what you're not and just be different. Thank you.
Thank you, Simon. So very inspirational and also very humbling for us who treat patients. And a couple of themes of that journey are very true and hit home, but it's important that we always listen to it and re-experience what the patient is experiencing. So next, we're going to move on to the CNET's research grants overview, and we'll look at some hopeful projects here.
Est-ce que le micro est on? Ah oui, OK, c'est bon. Merci. Okay, so I think I'm going to move, thankfully for this. So my name is Girish Shah. I am member of the board of director of CNETS Canada, and I'm also vice chair of research. So my project is, and my job in CNETS is to make sure that the research flourishes in our country. So I think that's my main job. I'm a professor at Laval University, and I'm also a researcher in CHU de Quebec Hospital. In the CHUL Hospital, I have my research lab. So I entered into neuroendocrine tumor field because of Dr. Richard Warner. He's from Mount Sinai, and he decided one fine day to meet me in Washington in a meeting, and then he said, why aren't you working on neuroendocrine tumor? And I said, what's neuroendocrine tumor? So that was my journey. It began about 20 years ago. And since then, I have collaborated with Dr. Jenny Spesieka, Jean-Mathieu Beauregard, and with Richard Warner. And we were lucky to make some breakthrough in identifying subclinical niacin deficiency in carcinoid cancer patients. So my interest remains always alive. And with Jean-Mathieu, we are particularly working on PRRT and how to improve PRRT. So I'll go through the journey. This is about me. Now it's about everybody else who is doing research in this field. So let's go. And where is the clicker? Forward. There you are. Okay, so Net Research Grant Program is something that was my mandate. Actually, Maureen Coleman, the former president of CNETS Canada, the founding president, she's the one who heard my talk, and she said that, why don't you join and let us do research, and how can we support research together? So she invited me to a presentation in Toronto, and I was actually very surprised, because this was a patient and medical specialist together. And there were patients who heard my talk and said, how can we support your research? Can we write a check to you? And I said, my God, there is a groundswell of support for net research. And I said, no, you can't give me. You give it to Maureen and CNETS, and that is how it will work. So I knew that there is a lot of demand. I mean, people feel very hopeful that if research is done, then there will be future treatment for the cancer, and therefore, I insisted, and that was my role in the board, as how do we go about increasing research in NETs. And working in NETs, I knew that it is really, really underappreciated and underfunded in Canada. So why? So I have asked a few questions for you. I'm sure it is in your mind. So what is this program? This program by CNETs Canada is to support clinical, am I have a pointer? I think so, yeah. So it's to support clinical and preclinical or fundamental research from cells to animals to models of NETs, and across Canada that aims to understand, and this is very important, how to improve diagnosis and therapy and understand this disease, because there is really not much information available, because it is classified as a rare disease, and then there are always these patients of neuroendocrine tumor are lost in general cancer therapy programs of every hospital. So we thought that, okay, is there some way we can do this? So why support net research? This was a question I asked because I am working in net research, and I know that it's very difficult to find fund for this. So we said that, and basically, why support any research? And you have an answer. Today's treatment was yesterday's research. Today, you're getting treated as patients because it was done 30 years ago, 50 years ago. Who knows when it was done? But today, you're getting radiotherapy, and today, you're getting chemotherapy, which was discovered in 1935 to 1955 period. So you can imagine, if you want tomorrow's treatment, a state-of-art treatment, you really need to go and look. I'm sorry, I keep clicking instead of pointing. So you need to really, today's treatment will arise from, tomorrow's treatment will arise from today's research. That's the reason. And the second reason why I did it is because there are not many options to receive the grant and lack of adequate attention to net research otherwise, because you get lost in other cancers and net does not get priority in funding. So this was my experience, and this was the experience of many others who are working. So we said, this is not how it's going to work. If I can just click back a little. This is back. Yeah, so that is why we decided that we will support net research. How do we support net research? This was the main challenge. We are a very small patient-driven organization, neuroendocrine CNETs. And therefore, we thought that, do we have resources to actually evaluate who should be funded or not? So one of the simpler solutions at that time in 2010, 2009 when I joined, I decided that really we are not equipped to do it. We don't know how to do it. We don't know what is the funding we will get. So the best way was I was working with Cancer Research Society. It's another Canadian organization that supports research. I was in their grant review committees, and I was a chair of many of the committees over there for several years. So I knew how they work. It's a very good organization that supports cancer research across the board since last 75 years, or more than 75 years now. So I suggested, and Maureen and other members of the board at that time accepted, that we will go with CRS and give them 50% for one grant that is dedicated to NETs research. And so this is the program that we ran for about 5 years. 2010 to 2014, our commitment was about $60,000 for a $120,000 grant. So this was how we thought that we will promote research. Obviously, it was not in our hand. It was CRS that was controlling everything. It has worked very well. Some of the grantees, one of the grantees you will hear today, who has got this grant too. And after 4 years or 5 years, we decided we should reassess. Is it really reaching the goal that we have? Our goal is really neuroendocrine tumor research. Not every cancer research, but NET is just one of those cancers. And I understand there is a value to that as well, but we feel that NET has so many other unmet needs in research that let us focus everybody on NET. Your model has to be NET. Your cells have to be NET. Your mouse has to be NET. Your clinical work should be NET. So there onwards, with the help of Rico and Jackie, who were together, in fact, it was Jackie's initiative that we focused a little bit more in that direction. Jackie was the subsequent president, and thank you, Jackie, for your support for all these programs that we have done. So we designed a totally new program, which was only for NET and run by us. So 2016 onwards, we have been running this program, and we have developed a new network. So what is this framework of the support? Mechanism to our NET research grant. By then, we were actually developing further. We have now Scientific and Medical Advisory Board that was appointed, and these are actually people, clinicians, and all levels of clinical association with neuroendocrine treatment. So with this board, we were confident that we will be in a position to choose the right grants to fund. We decided a few basic criteria. It has to be an open competition, and it should be open for everybody, NET clinicians and researchers across Canada. There are many research grant programs which will not allow clinical research. And there are clinical ones which will not allow fundamental research. So we said, no, everything is okay. As long as you work on NET, you are welcome to apply. We also said that CNETs consistently should award grant every year. People should know in their calendar that come this year, there will be a CNETs grant available, so that there is a reputation that we develop that we will consistently fund NET research. That required some amount of, advanced thinking. That board did very well. And I'm very happy that we have been able to do this every year, and you will see some statistics of how we have done it over years. Third point that we wanted to mention was Grant must be directly relevant to diagnosis, treatment, and understanding, which are our goals. So it has to, your model cannot say that I'm working on this gene which is on breast cancer. By chance, it is also on neck cancer. No, that doesn't work. Your model has to be on neck cancer. For that gene, we are good. So this is how we try to restrict everybody to work and promote, not restrict, I would say, but encourage them to work on net model. So this was our idea. And of course, we were lucky that peer review was by Scientific and Medical Advisory Board. We have all sorts of expertise, and we do not feel shy about seeking advice from external experts if the grant requires this expertise. So this was the program that we created. Very fast turnaround. You apply, and within 2-3 months, we are able to give you the result. We give you the money right away, and you have this advantage. The source of funds and input for grant programs objectives. So CNETS is a charitable organization. And as I already said, that patients were very keen to support. So our patients, their caregivers, people who are working in NED, including clinicians, including basic researchers, we are all highly supportive of this, and everybody runs. We run an excellent charity drive. For a size of our organization, it has been doing very well. And that is the one that is actually guaranteeing that we are giving this program and grants every year. So I'm very thankful to all the donors, many of them are over here, that this is really a source of our strength to run this program. So we have exceptional supporters whose campaign generates sufficient funds, and I'll talk about one of them, who generated so much fund in the drive, Danielle, that we are actually giving out a grant in her name so that her supporters create that much fund every year since last 3 or 4 years. That's right. So, and the last one is quantum and duration. This was a big debate. How much money to give, correct? Because if you go to CIHR, you are going to get $500,000, $1 million grant, maybe $5 million grant if it's clinical. We are not playing in that ball game. We don't have those resources, but we knew what we can do. And what we said is that if you have an idea, and if you go to CIHR with an idea, they will give you $0, because idea is not what they fund. They want to know the feasibility. They want to know, do you have primary data? You have preliminary data. Have you done for mouse model? Have you done with cells? Have you done with at least 10 patients to tell us that your idea is worth doing? So we said the amount we will give is $40,000. $40,000 is out of thin air that we plucked, because that was the kind of goal that we could achieve. And about $80,000 is what we collect as a donation. And so we said, okay, we'll give 2 grants of $40,000. This will be your seed money. Use this money wisely. Try out your new idea. If you get good data, go and search for millions of dollars. We have no problem with that. We are not daydreaming that you will do Nobel Prize winning research on our 40,000. But what you will do is, if you have a Nobel Prize winning idea, take it to us. We will give you the money so that you can get enough of preliminary data and go find more money. This is our basic idea. So we think that this is okay. And you will see the productivity of our program by many of the speakers who are going to be speaking today about the output from these grant programs. So, and we also thought that, okay, there is another choice. Can we give 80,000 to one lab, or 100,000 to one program, one researcher? And we decided that is perhaps not productive, because we have no idea what will be the next treatment of neuroendocrine tumor. We do not know whose idea will work. So we said, let 100 flowers bloom, to paraphrase Mao Zedong. And our idea was that let every idea that is there stand a fair chance. If they are getting funded, if they come up with a great idea, why not? So we would rather fund more at 40,000 than to fund one at 80,000. So this is how we work. We also think that our grant in aid allows recipient to test an idea, which I just mentioned, and then move forward. So who got the money? This is the list of 21 people who got the money, 21 grants, sorry. So these are the grantees whose name you see over here. I'm not going to read the list, but many of you who have been granted, you will see your name over here. I have just tried to divide it in the year. So these are the years in which we gave out the grants, 2010 to 2021. These are the 3 grants which are coming. So after hearing my talk, if you're encouraged to apply for a grant, please remember there are 3 grants coming this year. And we will really be happy if we want more people to apply. We want our success rate, our percentage success rate to go down dramatically, so that we know that we can go and ask patients and our donors to give more money to us, so we can fund as many grants as we can. So please try to do that. So here you can see what we did was, on an average, we give 2 grants a year. But there are years in which we are given 4 grants, and there are some years in which, for example, Daniel's constellation has been consistent in last 4 years, they have collected enough money to give an extra grant in their name. So then there are years in which we gave 4 grants, and it is distributed all across the country. I'll just show it in a few minutes. But what I want to tell is the number. Number is $1.1 million. For a small organization like us, $1.1 million is a lot of money. Thank you, thank you. And thank you to all of you who have done this excellent work of collecting the fund. And so how did we do it is because we just stayed consistent, as I said. Everybody in the room, everybody in Canada should know that we are there. If you are doing net research, we will support you, and therefore this is the best way to increase the awareness. And I'm not going to show you the statistics, but CRS actually showed me the statistics that when we started a program with them, there were only 2 applicants who said net research. By the time we finished 5 years with them, there were 13 applicants out of 260 who were doing net research. And I feel that is a success. We are increasing awareness. We are telling people there is an opportunity, please do research, whatever research that you can do. We are here for you. And this is what is showing over here, that these are so many of this. And so instead of reading every name, what I did was, what is our goal? Why are we giving the grant? So the next slide will divide them. If you want this data, I will tell Jackie and Rico to put it on our website so that people can see this data, because this is anyway open. It's all the data that I have culled from our website, so you can see it. So what I did was, this is a better way to tell you. What are we supporting? So as I said, we have 3 ideas: diagnosis and markers for the disease, which is directly relevant to the patient. How do you diagnose? What is the way in which diagnosis can be improved, and what are the markers which are being developed now currently? Second idea is the treatment. Can we improve the treatment, target the treatment, or identify a novel treatment? So this is the second category that you see over here. And the third one is understanding nets at molecular level. So yes, there are multiple endocrine neoplasia genes, MEN, and yes, there is very little known about, but some amount of research is going on, but we don't know what is the genetics of it. But nonetheless, there is a lot that can be done at the molecular and cellular level. People are doing transcriptomics, and people are doing proteomics, and many other ways in which it's being explored. So the newer technology is being applied to this disease by many of our grantees, some of our grantees, and we hope that this will come out more and more in future. So if you see over here, we are about equally funding all the thematics. These are the 3 themes of our research. Somewhere between 5 and 6 grants are given, and some of them have double names over here. So you can see that we are trying our best to distribute this. Do you think we are designing it? No. People are applying, because we are telling them that you apply, whatever is your thematic, we are here to support you. So this is the best way to go about doing it. We trust you as originator of ideas and applicants who will tell us, and we trust our patients and our supporters to give us the funding so that we can continue doing it. So with this, I will just tell you the last idea, and this is where I think that I'm encouraging some of you to think about it. Where have we funded in Canada? So let's say the 21 net research grant, we have funded 1 in British Columbia, 1 in Alberta, nothing in Saskatchewan, nothing in Manitoba. And do you think that net patients are not there? Do you think net treatment is not going on? Yes, it is going on. We want them to think about it and encourage them to find an idea that we will be more than happy to consider in a grant competition. Nobody has a guarantee. Remember, these are open grant competition, and there is a scientific review process that goes on. But if you don't apply, you don't get it. So please apply. And please hope for the best. Then, of course, the lion's share goes to Ontario, and I'm not complaining because Ontarians are really, really active. The organization began with a really very heavy base by Maureen Coleman and then Jackie. So I understand that, and there are lots of specialists in Ontario. So it's just to let you know that Ontario got 8 grants. Quebec is the next in line, which is about 5 grants. And you think that Quebec is the largest center in Canada treating NET? No. Just simply because Matthew and people like me who are there, and we are actively interested in this project, and there are many more clinicians and basic researchers who are interested in it and apply it. So please try. It's not that there is any favoritism we do over here. It is really an open competition. Kingston has 1, Kingston has 2, Ottawa has 1, Toronto has 8. Obviously, it's the largest center in Canada as well. So it's obvious. Montreal got 3, and Quebec City has got 5. So this is where we are. What we are missing is East Coast completely. So East Coast, there are patients. There are people in our board who are from East Coast. So I wish, and I hope that there will be more of this coming up. Then with this, I stop. I'm here for the whole day. If you have any questions, I'll be very happy to answer about this program. I would like to thank all the grantees for their research that will lead towards the future treatment. and we want more of you and your colleagues to do research, and we want more of you to donate for this cause. I will end my talk by announcing two things. One is that 3 more grants are coming. Remember, this year, very soon, they will be announced by CNETs. Apply for it when you can. And the second thing that I wanted to announce is that I have received, and for those of us who are working in this field, Cancers is a journal which invited me to edit a review and volume on advances in neuroendocrine tumor. And I encourage most of you to consider. With Simran Singh, I've been talking about it. Simran, I just announced without, I was looking for you, but Simran knows about it, and Simran and I will discuss together, and I encourage all of you experts to write your recent one review or original article on neuroendocrine tumor. We'll continue the good job, and my last announcement is that I have been in the research position in the CNETs for now more years than I can count. So in that case, I would suggest that there is a time for succession planning. If any of you are interested in joining the board in the research side of it, I'll be more than happy to pass on my reign to you. Thank you. Thank you very much. Okay.
Good? You can hear me now? Okay. I love your energy. I need to get like half your energy. It's excellent. You've done a fantastic job, and I agree. He's been a great advocate for CNETs as a research organization and trying to improve various aspects of this disease. So thank you. All right, so next, I think we're staying on time. Oh yeah, very good. We're even ahead of time. Oh my goodness. Okay, so the next part of the agenda, we're going to have Dr. Julie Halle to come up and speak about what's new in carcinoid heart disease management. And at the end of that presentation, then we'll have the panelists come up. We won't have the panelists come up right now, otherwise they won't see the presentation as well, so at the end. So as we know, Dr. Halle is a neuroendocrine surgeon in Sunnybrook, and she's looking for the, is it up here? No, you're good. Good? Okay. Okay. And she's going to speak on carcinoid heart disease. Thanks, Julie.
Like Lady Gaga? Seriously? Jackie, you're making my dreams come true.
There you go. Well, we can sing a song on there, Lady Gaga, if you want. You have to put it somewhere.
Karaoke style? Yeah, let's go with that. Okay, I don't know if that's gonna... Can you all hear me now? The other side? Oh. Oh, that way. Comme ça? I bet Lady Gaga has more people helping her with this.
They've given you one to help you, so.
And she's got, like, bigger wigs, too. Hey, c'est pas... Ouais, ça marche. Est-ce que vous m'entendez dans le micro? Non? All right. Okay, so this is working. Is that all right now? Okay. So thanks, everybody. Technical difficulties, but, you know, even Lady Gaga has some. So I'll be talking to you about carcinoid heart disease, just giving you a little idea of what's going on right now in Canada and some of the results from research we've been conducting in Ontario. Just before we start, I'm from Quebec City, so I wanted to just have a quick land acknowledgement, just recognizing that the land that we stand on today and where we gather is a traditional and ceded territory of the Huron-Wendat people. So we're grateful to be able to live and work on these lands. I have a few disclosures. Here in particular, I've got research support from Ipsen and Novartis over the years. I'm very grateful for it. So we all know about carcinoid syndrome, but a lot of what we know about carcinoid syndrome comes from this initial paper that was written in the very early 1970s. And that sort of has built a basis for what we understand. And what we understand is it all comes from serotonin. That's the current understanding. And that creates fibrosis. Now, there's more and more research being done into carcinoid syndrome and carcinoid response. And we understand that it's way more complex than all these serotonin secretion going into systemic circulation and leading to repercussions at a systemic level. There's also a lot of interactions with growth factors, the tumor microenvironment, and so patients that don't necessarily have a lot of metastatic disease can also suffer from some levels of carcinoid syndrome or some local repercussions from serotonin production. And we also understand that there's a lot of other factors that are being produced by the tumor that we may not even be able to identify yet that play a role in carcinoid syndrome and their repercussions. And carcinoid heart disease, all of you probably know that it happens in the right heart because serotonin comes more often from the intestinal tract tumor, and then when the liver is overwhelmed because of metastases, or metastases themselves are producing serotonin, it goes directly to the right heart, and then you have sort of deposits that create fibrosis on the tricuspid valve and the pulmonic valve. But there's also left-sided heart disease that can happen. And every time I talk about this with trainees in the operating room, they all come up with this. It's like when you have an intracardiac shunt that you can get this. And then the intracardiac shunt has to be reversed, so right to left, which is pretty unusual. Is my limited understanding of cardiology. I took a class in med school. But actually, it happens more often from long neuroendocrine that can be functional, or long metastases such that the lung cannot act as a filter against the serotonin. When there's just like overwhelming endocrine activity in the body, and like neither the lungs nor the liver can filter anything. So it's important to note it does exist, and it's more common than what we would think initially. Traditionally, those are numbers that, again, were reported in cohort studies back in the 80s and the 90s. So 4% of all neuroendocrine tumors will have carcinoid heart disease, and is reported that when patients have carcinoid syndrome, that will increase to 40%. And the most important thing is that it is associated with a significant reduction in survival. So there's a lot of what we talked about fibrosis with carcinoid syndrome, like retroperitoneal fibrosis, mesenteric fibrosis in the abdomen, that is associated with horrible symptoms, but does not impact survival. Carcinoid heart disease does. And those patients will have a 3 overall survival of 30%, compared to 70% in those without heart disease. So it's very important to be able to identify it, screen for it so we know about it early, and we can intervene. So what's going on in Canada? When I have data from Ontario. I know Canada is much bigger than Ontario. I grew up in Quebec. But I'll talk about what I have data for. So we looked at patients with small bowel and long neuroendocrine over 19 years. And why small bowel and long is because they are associated with serotonin secretion. That's what we're interested in. This is the breakdown. So the vast majority, again, 54% long, 46 small intestine, and 48% of those patients were metastatic, either at diagnosis or later on. The heart disease often happened within 12 months of the initial diagnosis of neuroendocrine tumor, so something that we can identify quickly, but you can see that the 75th percentile goes up to 55 months, so it's important to keep screening and keep paying attention over the course of the disease. Now, when we talk about heart disease, you'll notice I didn't put carcinoid heart disease there, is because like in our data sets are administrative, so we cannot say for sure it is carcinoid, but we have validated ways of identifying valve disease or new heart failure. And so we used that code after a neuroendocrine diagnosis and made the assumption that it is likely related to the neuroendocrine diagnosis. And you'll see that depending on the subgroup, that assumption may be a big leap or a small leap. So here is the incidence of what we found over time, and we accounted for the competing risk of death. So some patients die and will never have the opportunity to develop heart disease, so we accounted for that. So in all patients, 11% at 10 years developed heart disease. That was 9% for lung and about 13% for small bowel. So that's in all of those patients. Those that have metastatic disease had higher rates than those without metastases, so that makes sense, right? I think it brings face validity to what we found. And then the patients that are functional, so where we were able to confirm that there was an elevation in 5-HIAA, and that's only a subgroup of patients because we don't have that data on everybody in the province. the incidence was higher than if they have normal activity. So again, I think that in this group where you know that D5-HIA is elevated, I think making the relationship between the heart disease that occurs after diagnosis and the diagnosis of neuroendocrine is probably less than a leap of faith than in the entire population. And I'd be pretty confident thinking that this actually represents carcinoid heart disease. What are the risk factors? So patients with a high comorbidity burden, small bowel primary, or those who were confirmed functional had higher risk of developing carcinoid heart disease. So again, I think there is a lot of face validity to this. And then what we're interested in knowing is how do we use echo in those patients? Because at the end of the day, if we don't echo, we cannot find it, right? We know that in neuroendocrine tumors, if you don't think about it, you can't detect it. So same for carcinoid heart. So looked at the rates of echo use after diagnosis. So 65% of patients at 10 years will eventually have an echocardiogram performed at some point. And then we looked at different subgroups. What I wanted to see is like, are we using echo in a smart way in the patients that are most at risk, or is it like all over the place? And the answer is, it's all over the place. So in all subgroups, no matter how I cut that data, over 50% of patients ended up having an echo. So it didn't seem to be really related to the characteristics of the disease, but a little haphazard. There is one group where there was a higher rate of echo, and that was in those patients with elevated 5-HIA, which again makes sense. And so I think what we're taking from this, it's very small cohort, it's very basic work, but you know, the incidence of heart disease in all small bowel and lung nets was about 10% at 10 years, which is higher than what historically is reported. Now, we may be overestimating because there might be others that are not related to heart disease, could be ischemic or other, but I think it's a bit higher than what we think of. And in those patients with serotonin secretion, it goes up to 15%, and that's lower than historical. And there, I don't know if it's because now we're actually screening more patients with an echo that have elevated 5-HIA, and in the past, only the patients that were very symptomatic ended up being treated, or we did not know about carcinoid syndrome in some patients, so it couldn't be identified. But that's an interesting finding. And more importantly, for what we're going to do next is we did not identify any pattern to how we use echo in our neuroendocrine patients. Like I said, it's all over the place. It had no relationship with the characteristics of the disease. So there didn't seem to be like a very standardized or pre-rational way to do this. And I wonder when we do that if we have a risk of under-detecting heart disease. There's probably a lot of patients out there that have heart disease and they will never get an echo, so they will never get treated until it's too late. And like we talked at the beginning, this is contributing to high mortality rates in that population. And if their heart is okay, we know that they can live longer, and they can live for many years with this cancer. So we often say, when you think about zebras, if you don't think about it, you can't detect it. That's true for neuroendocrine tumors. That's true for carcinoid heart disease. So within the treatment of our neuroendocrine tumor patients, we have to think about it as well. So next, what we're going to be doing, and I hope we'll be able to touch upon that with the panel cases, is about working on awareness. So showing this data so people know that it exists, know that we're probably under detecting it and we need to do better. Working on how we can screen those patients. There's a number of guidelines that are ongoing right now, and we'll talk about this with Dr. Ahmed on the panel, because I know she has thoughts on that. Making sure those patients also get to expert teams and get expert treatment with multidisciplinary teams. And the multidisciplinary team needs to be expanded to cardiologist, internal medicine, anesthesiology for the patients that go to DOR, cardiac surgery. And so that's what we're going to try to address on the panel today. And the expert team is so they really get to timely cardiac treatment. And the last aspect for those of you who are oncologists in the room is how do we get better endocrine control? Because even if we treat those patients, either their valve disease is going to get worse if the endocrine activity remains high, or like we'll see in one of the cases I'm going to present, the new valves can actually become diseased as well if we don't control the hormonal component well. And I know we have some drug funding challenges with that right now in Canada, so we'll discuss that in the panel. All right, so I'll invite a panel to go sit right over here. You don't have Lady Gaga mics, that's only for me. You have normal ones. And while they do that, just highlighting this photo, this is a CN Tower in 2018 for Neuroendocrine Tumor Cancer Day that done white and black stripes for Zebra Day. a photo from Dr. Law, who is over there with his camera. So he will be pointing the camera at you this weekend, I'm pretty sure. All right, we can go to the other presentation. Am I on time, Jackie?
Maybe we'll check. Can you hear?
Ooh, nice. Okay, first panel.
So Julie, do you want us to go down the panel, who's who, or do you think?
What do you think? What? Yeah, because you can't
Yeah.
see, right?
We might just have to turn and then turn around.
Yeah,
That's it.
maybe.
So I guess we'll just pass on who's who here. So I'm Rachel Goodwin, medical oncologist in Ottawa.
I'm Stephanie Ladowski. I'm a cardiac anesthesiologist at Sunnybrook in Toronto.
Good morning, I'm Shahida M. and I'm a cardiologist also at Sunnybrook Hospital in Toronto.
I'm Kirsty Lithgow. I'm an endocrinologist from Calgary.
And I'm Isabelle Dier. I'm a surgical oncologist in Quebec.
All right, so fun panel, lots of people I worked with, people who trained me as well. So I just wanted to start with a little quiz. I did that at last meeting we had in person, so I wanted to see if people's zebra knowledge had improved over time. So we'll have those through the presentation. So ladies, do you know how fast can zebras run? Any guess? Faster than you? Faster than a horse? Slower than your car? Dr. Lithgow is going, yeah, to all these answers. 40? 65, not fast, yeah. I did lots of Googling about zebras on the flight. So zebras can run fast, so we need to catch up and keep up with them. So the first case we're gonna present is that a 40-year-old gentleman who has no past medical history, very healthy man, very physically active. And then the 6 months before we saw him, he was having very frequent watery diarrhea, 7 to 10 a day, lots of fatigue, lots of energy. Went to his family doctor and was diagnosed with gastroenteritis, depression, and increased stress. Simon, that rings a bell? Yeah? And so that's what was happening. And by the time that we saw him in our clinic, he started having flushing 12 times a day, about that. He had 10 bowel movements during the day and about 4 to 5 at night. He also had debilitating abdominal crampy pain. He lost 34 pounds in 3 months. And he started developing bilateral lower extremity edema and shortness of breath going up one flight of stairs for somebody who was like an active runner prior to this. In the clinic, that's not my exam, that's Dr. Singh's exam, because I'm a surgeon, so I don't have a stethoscope. But as he is standing, we see that he has his GVP is visible as he is just seating. When he lies down, we cannot see it anymore, probably because it's too high, is what I learned. He has a tricuspid murmur. He has very severe bilateral lower extremity edema, and you can feel hepatomegaly on exam, and he has right upper quadrant pain. So that's what we see in our multidisciplinary oncology clinic. And then he came in with a CT scan, and that's a report from the CT. I really literally copy-pasted the conclusion from the CT scan. Multiple liver mets, bony mets are seen in T12, L1, L4, and T8. And that's it. So that's what we got. So where are we going next with this? Maybe I'll address that to Dr. Goodwin, because you would see those patients in your clinic. What do you tell him, and where are we going next?
I think it's on now. Okay. So clearly, we're worried about this gentleman in terms of carcinoid heart disease, and I think that's probably the most pressing issue that we need to deal with. So urgent referrals. Certainly, the watery diarrhea is related to the carcinoid disease as well. We're likely thinking this is a small bowel primary with this presentation. So I'm not seeing that part has been worked up yet, whereas this primary, so we'll need to do the appropriate scans and imaging in order to determine that. We're wanting to start SSA treatment for symptom control, and at the same time, we're considering that it might not be enough with this gentleman, and we're probably going to have to go after disease on the liver control in order to get his symptoms under better control. But at the same time, you're worried, can he undergo some of these procedures with the cardiac issues?
Absolutely. Dr. Lidgow for the
Well,
endocrine control.
I'm an endocrinologist, so I want biochemistry. So I would like to, quantify his 5-HIAA levels sort of as a baseline right now prior to starting treatment.
Yeah. And Dr. Ahmed, do you want an echo? Transthoracic okay for now? Awesome. We each have our own tools. I have Dr. Singh and Dr. Meyerhawk for a stethoscope. All right, so this gentleman undergoes a liver biopsy to confirm a diagnosis, shows neuroendocrine tumor that's well differentiated with a Ki67 of 2%. I learned at NANETS last week that we say Ki67 and not Ki67, so I'm trying to be better at it. Pathologists told me that. We ordered a CT angiogram, I'll show you right after, and a transthoracic echo, and we had a 24-hour urinary 5-HIA at 4,500, and the normal in our lab is below 40. So a sick patient. How is this going to work? All right. So that's a CT angiogram. Isabel, I don't know if you can see it from where you are. Okay. He's very thin, as you can see, so it's hard. The assessment on the bowel is difficult because there's no fat to look at it differently. But essentially, bilobar, multiple liver metastases almost all over the liver with hepatomegaly. There is also this sort of, if you've seen the densities in the liver are kind of different, and that's on the right side of heart strain that creates that. And they saw a 1.4 centimeter small bowel lesion associated with some enlarged lymph nodes just by the edge of the bowel wall. So that's what we've got. And that's the echo. Now I screenshot that, but is that enough? Do you have everything you need there, Dr. Ahmed? And you've seen him before. Yes. Hi.
What you look for, I'm sure you're all familiar with it, but the right-sided dimensions is the first thing that you screen very quickly for. And I just want to make a point that, like, I'm an echo doc, and echo is great as a screening tool. The right ventricle is shaped like a croissant. It's like your croissant, and it's adjacent to the left ventricle, which is like a coffee cup. So depending on how you cut it, you can get a very normal measurement or a very abnormal measurement. So the presence of an abnormal measurement on your echo should be a red flag that you really do have an abnormal RV. But the corollary is that if you have a normal RV measurement, it doesn't necessarily mean that the RV is normal, because if you don't cut it correctly, you might be oblique. So that's the first thing. And then the second thing is the TR gradient, which is a reflection of the pressure difference between the right atrium and the right ventricle and what is regurgitating backwards, doesn't really help us much in carcinoid. Often by the time we see them, they have free-flowing TR, so there isn't very much of a pressure gradient. And so a low TR gradient doesn't mean that you don't have severe TR, point number one. And point number two, in normal people, TR gradient is used to estimate pulmonary pressures and pulmonary hypertension. When you have free-flowing TR and you have a low TR gradient, all bets are off. It doesn't tell you whether or not the patient has associated pulmonary hypertension with that.
Yeah, so that's why we have Dr. Ahmed as cardiologist who specializes in carcinoid heart disease. I gotta say that recently we've had issues getting echoes at Sunnybrook because of understaffing, so I've been sending the patients for outside echo, and we do not get the same level of interpretation that we get with somebody who specializes in that disease. Now, we have this. Do you want to initiate any therapy? How we are approaching him at this time?
I want to see the pictures.
I want to see the pictures. I don't have them because they're not on SunnyCare.
You should have told me. I would have got you clips.
Yeah.
No, definitely. You need to see the patient clinically. So A, what do you look like? B, what is your functional capacity in your NYHA class? C, are you volume overloaded? And then D, what's the next step in the big picture? How does the heart piece fit into the bigger picture of you and what's going on?
Yeah, so we'll talk about this. Now, this patient, we're going to talk about the heart. I'm in Quebec City, so I had to bring her up. Did you know that? Oh.
Yes, I knew
I gotta up my game. I'm becoming predictable. All right. So yeah, talking about a heart, we discussed the echo, like the initial treatment. Dr. Goodwin mentioned that we're going to have to consider whether patients can withstand therapies for liver-directed control. So that's either liver embolization we can use surgery. Dr. Ledowski, what are your considerations? We're looking at bringing this patient to the operating room in his current condition. Would you be happy with him or happy with me suggesting that?
We'll take whatever you give us in the operating room, Julie, and we'll manage. So obviously we think of when we see these patients in clinic or are planning for them intraoperatively, we're considering multiple different things. Initially, we want to have an idea of what their symptom control is like, and that's in many regards, right? So whether it's in regards to the respiratory system and what we think are risk of bronchospasm from the beginning, right, with our induction, their biochemical profiles, and any potential electrolyte abnormalities that they have. With patients coming in with carcinoid heart, right, we're not just worried about the heart, we're worried about congestion that is occurring behind it, right, in the system. So any congestive hepatopathy we're dealing with, right, so regardless of whatever surgery they're coming in for, any impact on the renal system that we have now, right, how that's going to affect, in both those regards, not just about bleeding, but how it's going to affect our drug dosing, clearance of medications, the basics. And then, of course, in regards to the right heart, as Shahida was alluding to, the right heart is far more complex in how it functions than the left heart. And it's a lot easier for us to support the left heart in the operating room than it is a truly failing right heart. And it's made that much more complicated in the context of neuroendocrine tumors, where agents we would otherwise give for the right heart may or may not exacerbate any crises that might occur in the operating room. So that doesn't mean, obviously, that we will stay away from those medications completely. We have to support the heart if we have to support the heart. But in those regards, we particularly care about their symptom management because we need a reasonable amount, usually of octreotide on board, in order for us to feel more safe in our use of beta-adrenergic agents. So while going through the history, we really want to know about their functional status and how they're actually doing from a symptom management.
So for octreotide, I guess a combination of long-acting and then short-acting on top of that. Dr. Goodwin, Dr. Lidgo, is that about right?
Yeah, and kind of intraoperative IV octreotide would be a consideration. I think that they're still going to have a high burden of 5-HIAA, even if they've had a dose or two of long-acting somatostatin analog. And then, the final thing I think about, which I don't think there's good evidence for as of yet, but just in terms of, could we further optimize them with putting them on telotrestat or something preoperatively if that's available and feasible for the patient.
And then so we're looking at endocrine control. SSAs can only do so much. We mentioned that. Dr. Dia, what are you thinking of when you see those scary CT scan images?
Yes. So I think that surgery, it's not the first step, definitely for that patient, like everybody says here. So we have to approach him step by step. The first step, I will not sing the step by step. So the first step is to take control of the carcinoid syndrome with somatostatin or sandostatin and also short-acting medication. And when we will have a better control of the nutritional status of the patient also. Second step is to make sure that the heart is stable. And third step, I wouldn't take him to the OR yet. We have to decrease the tumor burden in the liver. So we have different ways to do it. I don't think it will be surgery for this guy, but maybe, or this woman, I'm not sure what is the sex is. So we can do like bland embolization or Y90 if you have a lot of money. And it's really important to have a good symptom control before, because the tumor will make more serotonin and all the other things during the embolization. So we always prepare them with octreotide perfusion before and after. And when he is stable, tumor is decreased, we can talk about surgery after, mainly directed to the primary and to prevent bowel occlusion and mesenteric fibrosis. So for the liver, I think it's a little bit too much.
out of the operating room. So we have multiple sort of challenges here and competing aspects of this disease that we need to treat. So the primary, the carcinoid syndrome, the METs, and then quite severe heart disease. He's very, very debilitated by that. So we talked about everything we need to do. Dr. Dea, you suggested starting with the heart. The question I always get from Dr. Hamed, and then the heart surgeon who work with us, Dr. Cohen, is, can I go right now, or do I need to bring the 5-HIA down? Are you going to embolize or operate on the liver first, or do I do before I do the heart? Like, how can you help me here? Any thoughts on that? How much do we need, like beyond the SSAs, how much do we need to try to bring the 5-HIA down before we put them through potentially heart surgery? I don't have the answer to that. I always go patient by patient and have individual discussions with Dr. Cohen most often. But in this case, this patient was being considered for valve replacement. Dr. Hamed, when would you consider valve replacement versus medical management of those patients?
The easy answer to that is if you're symptomatic, all other things being equal, and you have a long-term prognosis that is reasonable, at least 1 year, with evidence of obviously right-sided volume overload, secondary to carcinoid heart disease from the tricuspid plus or minus the pulmonic valve. The harder answer is when there's other things going on, because we personally, not personally from me, but the guidelines would suggest that you want your urinary 5-HIA levels to be as low as possible and preferably less than 300 after you've operated to improve cardiac outcomes. So that's where it becomes a bit difficult in figuring out what you do first, and that requires discussion.
Yes, in this gentleman, we had very long discussions, including cardiac surgeon asking us what's the exact prognosis, because he was very reluctant to do a valve replacement on somebody with widespread metastatic disease. So we had very long discussions about the fact that those patients had a prognosis that's beyond 5 years, and you'll see what happened to him. And with that, we're able to convince him that it was worth going for it. And that was a useful discussion, because after that, all the other patients we've had, we go to the same surgeon, so we don't have to have that conversation again. So it's good to have those discussions, involve your heart surgeons, have somebody that you can call on. And then we
Julie, a question. For a patient like this, unstable, and if you were to decide to embolize, do you have anesthesia go to the embolization?
That's a very good question. Our team, so we talked with an IR for this to embolize prior to heart surgery to bring the 5-HIA down, and they were reluctant to do it because the patient at that time it was getting more and more difficult for him to lie down without not respiratory failure, but let's say significant challenges. So we've had anesthesia go down for IR, Dr. Radowski.
Did in Ottawa, we had a patient that was unstable with issues like this, and we had anesthesia go, and it went much smoother.
Yeah, especially if they need to get intubated or there's any complication through the procedure, it's better that than calling a code blue to the IR suite, which we've seen happen too. So this gentleman, we weren't gonna, there's no role for liver debulking. There's too much liver disease. Liver embolization was not deemed safe, and he was very, very symptomatic, progressively getting worse. So we went for heart surgery first, is what we started with, and recovered after that. So they did pulmonic and tricuspid valve replacement with bioprosthesis. He did quite well, good echo from what I could see after his surgery a few months after, went through his cardiac rehab. And after that, we completed a small bowel resection. And following the small bowel resection, went on with liver embolization. The reason we did the small bowel before liver embolization is because he was significantly improved after the valve replacements, and now his main problem was crampy abdominal pain, so we wanted to treat that first. And then he continued on somatostatin analogs. After all the treatment, his 5-HIE came down significantly over time, down to never completely normal, but we started so high. So just for the little story of what happened to him afterwards, 2.5 years after all the initial treatments, his 5-HIE is rising now, going up closer to thousands, flushing and diarrhea recurring. His disease is progressing in the liver, the bones, and the peritoneum. So he was put on PRRT and was treated like that, had some response or some improvement. Unfortunately, 3 years after, with that level of 5-HIE remaining high, he had recurrence of tricuspid and pulmonic regurgitation on the new valves. So again, the importance of maintaining good disease control, good endocrine control. We had a number of rounds of repeat embolization for him to again try to bring that down. But I was curious to hear Dr. Goodwin and Dr. Lithgow speak to drugs for endocrine management and your thoughts in particular. And I know it's not indicated or funded yet, but the role of telotrestat in trying to maintain those 5-HIE levels down.
Experience with one patient who has had severe carcinoid heart disease, and we did use telotrestat preoperatively in this individual. That he had widespread metastatic disease, so he didn't go for any resection of his primary, but he did go for valve replacement, and he did well with that medical therapy, and he remains on telotrestat with quite good control of his levels, but that's obviously very limited experience, but I think it's an important area of further investigation is what the role is of this in terms of carcinoid heart. I know it's very effective in patients for symptom management, but beyond that, we don't have great evidence, but I'm very interested to know more.
So in Ottawa, we have not used it for that experience, but certainly if you go back to the clinical trial and in our personal experience, we do see extreme responders in terms of their symptoms getting much better. And the study did monitor urine for 5-HIAA, and it did come down nicely. But I would urge these kind of cases to be written up, right? Because the rest of us won't learn unless we see that experience.
Yeah, absolutely. And I think there's a small prospective trial going on at Moffitt. I think it's Moffitt right now, where they're looking at telotrestat in patients with carcinoid heart disease to get better control of their urinary 5-HIE and see whether that improves their outcomes or their prognosis. I'm very excited to see those results, and hopefully in the future we'll be able to do that. As patients can be symptom-free or cope with their symptoms in a way that they're not reporting symptoms, but their 5-HIE is still high, and that's still damaging the heart, and we see some pretty terrible things. So this man survived for 4 years after his initial presentation. All right, so we talked about the endocrine control. Next, just zebra quiz before we go to case number 2. Anybody knows how zebras sleep? Standing up, yeah, like horses. They are part of the horses and donkey family, I learned yesterday.
One leg at a time raised.
Really?
For whatever reason.
Oh.
Horses do that.
Interesting. There you go.
Penny entertains our children with her horses. She's one of the nurses in the GI clinic.
Oh, that's awesome. Maybe you'll need to add a zebra to the stable. Well, the zebras, they are everywhere. So, Thor Hafdenerson, who's a medical oncologist in endocrine tumor at Mayo, keeps telling us how on his bike ride, there's a zebra in Rochester, Minnesota, and he takes bike rides to visit the zebra regularly.
Penny competes at, what do you compete at? Endurance riding? Yeah, endurance riding. Maybe you should show up with a zebra next time.
Dr. Shah did say that if you want to study anything related to neuroendocrine, he's there to help you. Right. So the second case is another younger gentleman, and Dr. Ahmed, you might remember him as well. So he's a gentleman who has a history of seizure disorder and developmental delay. He's a very active person. He actually does snowshoe racing, is like as a competitive level. He's on medication for his seizures. And in the past 3 years, he was complaining of fatigue, diarrhea, and flushing. Like many patients, visited a number of healthcare providers and didn't get a definitive diagnosis. And I think all that was also compounded by the issues with his developmental delay, that some of his cries for help were not necessarily taken seriously. And so that's sort of what he looked, that's not him, but that's somebody who could look like him, who looked like when he shows up in clinic. He walks into the clinic, he's like clearly flushed. And then he has also a tricuspid murmur that I did not listen to. And he arrives with those investigations. He had an echo a year prior, so because of the fatigue and whatnot, he had an echo in an outside private institution. And I remember that report because at the bottom it says, there's valve disease, and that's it. And the echo report sat there. And he had an outside scan a month before seeing us, showing a hypervascular mesenteric mass, innumerable liver metastases. The large one is about 4 centimeters, and he does have a sclerotic lesion in his bony pelvis. So same type of workup as we did for the prior gentleman. He has a grade 1 neuroendocrine tumor, well differentiated with a Ki67 or 3.2%. His 5-HI is 110, so elevated, over 40, but not as high as the other patient. This is his transthoracic echo read by Dr. Hamed at Sunnybrook. So same comments as like what we talked about before, but essentially thickening of the pulmonic valve and moderate pulmonic regurgitation. There's also a suspicion of patent foramen ovale. And so this is what his CTs look like. I didn't have video back then. So that's our arterial phase for the mesenteric mass. So the mesenteric mass starts right here. I point with this. So right here around the SMA axis. Again, you can see it hyper-enhancing there. More of it right there. And then you have this sort of infiltration along the vessels, the mesenteric vessels, that's typical of the desmoplastic reaction in neuroendocrine tumors. And now this is his liver MRI. We do liver MRI with Primavist for detection of metastases. Oop. There's supposed to be a video here. How do I do that? Are we able to click on the play for the video? I don't know if that works. Okay, well, we'll go without them. I have other photos after. So a bit of a different story, not as symptomatic from a heart perspective. We have like bilobar liver metastases. There is a dominant one that's about 4 centimeters, and there's other ones that are scattered throughout the liver, involving all segments of the liver. He has a primary tumor in situ with a mesenteric mass and elevated 5-HIA and symptomatic from a carcinoid perspective. Now, how would you approach this patient? We'll start with Dr. Goodwin, and we'll talk about surgery.
So certainly with this gentleman, at our first initial consult, we would make sure that all the key players are consulted and involved. Surgery, in particular hepatobiliary surgery, medical oncology, I think at our consult, the first initial issue is going to be starting SSA, so long-acting somatostatin analogs. I think because his diarrhea management is not as bad as the first case, I think he's going to see some good control. And also teaching him that if he needs short-acting for rescue, then making sure that that's available and taught as well. And that would be our initial workup. But I agree with that dominant liver lesion. Once again, you're probably going to have to deal with that issue to bring down the hormone levels.
Yeah. I gave out the punch. Dr. Litko, sorry.
Always start SSA, so I agree with that.
Is there, we tend to rely a lot on urinary 5-HIA to measure serotonin level as a metabolite of serotonin. Do you have any experience with using serum serotonin, for example, or I know there's a bunch of new biochemistry testing that's coming up. That might be more patient-friendly.
But I think that, seeing the patient's tumor burden, carcinoid heart disease, and the fairly modest elevation of 5-HIA in this case certainly points to the limitation of using that exclusively as a biomarker, where I would say in the previous case that, level is probably more in keeping with the extent of disease. So just something to keep in mind.
Yeah, does anybody have experience using serum serotonin? Yeah.
Actually did serum level, urinary 5-HIAA, and biochemical deficiency of niacin, and all three parameters were really matching. If serotonin was high in serum, then definitely there was urinary 5-HIAA was high.
It's
So
nice
it
to
is
see,
doable,
yeah.
it is there. Our clinical side, they have a standard way of analyzing. I went to Sherbrooke at that time, but I think now Sherbrooke also has it.
Oh, wonderful.
It's
I wonder.
center at that time.
I wonder if we're going to move towards that, because the urinary 5-HI is definitely very cumbersome for patients. And I know clinically, when we want to repeat it, we're often like stop ourselves and we'll do fewer of them because it's so difficult for patients, especially when they come from far, they have to collect their urine and then you have to come back to the lab to bring it back in.
And importantly, there are many dietary restrictions they have to follow, such as coffee. So I don't know, I'd feel pretty annoyed if someone told me I had to, and then sometimes that happens and the lab loses the collection, or there's an analytical error or something. So that's always a heartbreaker.
So Juris, that might be a nice part for your paper in cancers, right? Some of the more novel biomarker and what's ready for prime time and what's not.
And so finally, Dr. Dea, we're looking at bilobar, multiple liver metastases. There is one dominant one on the right side, and there's a bunch of very small ones scattered through all segments. And this mesenteric mass, a patient with undergoing abdominal pain. What's going through your mind?
We were not able to see the MRI, but I suppose there is no surgery possible for that guy, like not possible to remove all the meds.
Not possible to remove everything, not
Okay.
possible to do a 70% even with.
Okay, and on the CAT scan, it was a little bit fast for me,
Yeah.
but I would like to know how many artery branch are free from tumor at the root of the superior mesenteric artery. So is there at least 4 or 5 branches?
Yeah. So I have them later on. I'll highlight it, but there's one right here. First little one. There's one here. And then there's, these little ones that are around the tumor, but not in it. And that carry on right there, the same ones lower down.
Okay, so the goal is to see if we can resect the mesenteric disease without giving him a too short small gut syndrome. And if it's resectable, if I have at least 4 to 5 artery branches that are free, we would like to do it. But first, the goal is to control the liver disease. So I will not rush him to operate on his small bowel first. So I would like to have the embolization and take control of the serotonin secretion and all the other stuff before.
That's a patient I had when I had first started on staff. So I read my note yesterday, and I was very interested by how I discussed my very long discussion with Dr. Law about where to go next, and how we supported the plan we had.
And Julie, is there any data taking out just the primary and not going up to the root of the rest of the disease? Like, because sometimes it's just not possible. I don't know if the data gets to that level. I don't think. Do you know?
The data doesn't go there. The data don't go there. I would say that our experience is that sometimes we have to do it. Like we've done, actually just last week, a case where we had to really crack the tumor off the SMA branches. So there is it's not only an R1, like millimeter microscopic disease left, there is an R2, there are like little pieces of tumor left on it. But when we operated, this woman had lost over 50 pounds in the past year. She was unable to eat. She was like dying of hunger at home, essentially. And the piece of intestine that was involved was purple when we got in. So leaving that in would provide her with absolutely no benefit. So we chose to leave tumor in and really like cracked it out. So we've been doing it. I don't know that there is any data on that. Other thing that we've done in those patients where we cannot even do that because it's too extensive is palliative enterectomy. I don't recommend it in the first instance, but we've done about, in the past year and during COVID, we had pretty horrible presentation. We still have about 3 of them that are on home TPN. It does require a lot of counseling before. It's not something that we decide on the spot in the operating room. Like, we have to have planned for it because they're left with often a proximal jejunostomy and TPN for life, like they cannot eat. Some patients will take that over debilitating abdominal pain. No data, maybe we should. It's all, it will be like very small case series, but might be interesting. Maybe we'll join with Dr. Shaw. So this patient had liver embolization, so blend embolization initially, like Dr. Dea mentioned, to get good hormonal control first. We almost normalized his 5-HIA to 44. And after that, we went for, actually the liver first. So we repeated the scans after, and he had sort of this mixed radiologic response, where some of the lesions had completely disappeared, but some of the larger ones were still present and still had uptake. There was another ideal sequences, but some of the larger Mets did not really respond to the embolization. And then the little satellite ones you can see right here, did not respond really well, the ones with the red arrows. So we did well from an endocrine perspective, but there was still active disease despite the multiple rounds of embolization. So what next? We talked about going for surgery next for the small bowel, and then potentially we'll see what we've done with the liver. Here is what we talked about with Dr. Dea. It's the little branches that we can save. So those are the ones here that I pointed out that we thought that could be saved. And one of the keys when we look at this, if you want to look at them and convince your surgeons, is this sort of scalloping of the artery. Like, we see that there is tumor around them, but so long as the border, the edge of the vessel is smooth, we'll be able to get the tumor off. If there's scalloping and you can really see indentation on the edge of the artery, then that's something that really will not come off, or will come off with a lot of blood loss and loss of bowel. So we don't try to save those. So this one, we went in for surgery on this patient. So we've got somebody still with heart disease, right? He had some tricuspid and regurgitation that was deemed not eligible for heart valve surgery. So he's being treated medically. He's improved with Dr. Hamed's great care. But we want to take him for surgery. We want to target the small bowel. We wanted to potentially look at the liver for those lesions that did not respond to the embolization now. Are we ready for surgery? Do we need anything else? Dr. Ledowski, I sent him to you in clinic. As a good surgeon, I've done no preoperative testing. I try not to do that because then I'm going to lose friends in the anesthesiology department.
Never. We're always your friend. So look, I think obviously as a cardiac and anesthesiologist, part of what I want first is cardiac testing, right? Basics in regards to rhythm and an ECG, if I'm at all concerned, right, about ventricular dilatation and dysfunction and increased pressure settings. A recent echo would be lovely, just to see, again, valvular conditions that go beyond a comment at the end that just says there is valvular disease, and just overall RV size dynamics, and if there was query in regards to PFO, or in addition to the fact that there is obviously a large burden of disease, whether or not it's impacting the left ventricle as well, or if it's all just right-sided. Obviously, again, I want to know about his symptomatology, any other end organ dysfunction, okay, secondary to both the underlying disease, but also the underlying heart disease. So we're pretty happy with just basic panels of blood work, just to get a sense of stuff.
And how recent should the echo be? Because a lot of us see those patients and wonder, should we repeat the echo before sending them? And somebody like our community partners that may not want to send to Sunnybrook for an echo.
That's an excellent question. I mean, it's going to depend as to whether or not there's been a dramatic change in functional status to be perfectly honest. If you give me an echo that's 6 months old and the patient is stable from a functional standpoint, we're going to assume that we're starting off the case in roughly the same place. And if we're running into issues that do not align with what we know from a history standpoint, I can drop in a transesophageal probe and better assess where we're at. Because in the operating room, if I'm running into hemodynamic issues, right, it's always a balance between am I in the midst of a crisis, and it's more of an SVR issue in addition to potential ventilation problems that I'm now running into, which are going to further exacerbate any underlying right heart dysfunction that I have, because a lot of what I'm dealing with in the operating room are sort of basic motherhood steps to try to support the right ventricle before I move towards support with inotropy, right? So I need to, the loading conditions, the right ventricle is very sensitive to its loading conditions, and a good chunk of that has to do with the tone of the pulmonary arterial system. So the basics of appropriate oxygenation, right? Preventing hypercarbia, both of which are impacted if I end up in a bronchospastic crisis, right? Have to be managed appropriately. So we take steps to try to prevent, okay, a crisis to begin with, right? And that's just not solely around octreotide dosing, but around minimizing use of medications that could potentially lead to histamine release. So basics around my opioid selection, decisions around which neuromuscular blocking agents I'm going to use, okay, in order to facilitate surgical conditions so you can do whatever resection is required. We'll pretty much always pre-dose with antihistamines preemptively. We'll pre-dose with steroids to try to help in minimizing risks of bronchospasm. As we're trying to, we don't often like to use salbutamol just because of its beta-adrenergic effects when treating a bronchospastic crisis.
So there's lots of moving pieces here.
Lots and lots of moving pieces.
And then to add to this, when we touch the liver, we ask for no volume. We want to have like hypovolemic patients to limit blood loss from the liver, especially when there's like increased pressure from the right-sided heart and the right ventricle is load dependent. Do we need, as I said, like patients that we're approaching like that for surgery, be it for the primary or for other indications? You think we need to have cardiac anesthesiologists or somebody around? Should these patients be operated on in centers that have that expertise available?
So I'll have to say for patients, particularly who are coming in with right-sided heart disease in these contexts, the resection of liver disease is a far more nuanced surgery from our end than even if they're coming in for valvular replacements. And that's because, as Julie is alluding to, when I'm dealing with them for cardiac surgery, there's certain goals that I have that align very well with the goals of the surgeon in my room. I do not want to overload my right ventricle. It does not want to be overloaded by volume, but I cannot keep it dry as a crisp. It is very sensitive to its loading conditions. So I cannot be aiming for a negative CVP. I will have no forward flow.
But I want a negative CVP.
So what I'll say is in these contexts, a couple things have to be remembered. So one is I have to maintain some volume on board. During times of resection, even though I cannot remove all volume, I can potentially take steps to try to minimize some of the bleeding with medications that are that I can titrate, that are easily reversible, and the main one is nitro. Okay, so I can try to decrease preloading conditions in that regard so that I can actually try to minimize bleeding. But in addition to that, as we've already been discussing in the context of congestive hepatopathies, there is only so much I can do to help with bleeding if there's a lot of back pressure from the right heart.
I'll show you where we're heading now. So we're getting to that. So we went for surgery on this patient. First off, we found 15 tumors, all within about 10 centimeter from the ileocecal valve. They're all here. There was 300 centimeter of bowel free from the angle of Treitz to where those tumors start. So we need about minimum 150, ideally 200, and ideally preserving the ileocecal valve to prevent short gut syndrome and have good function for patients. So what we did is this mesenteric sparing bowel resection. What I mean by that is traditionally, sorry for the gruesome pictures for the non-surgeons in the room. Traditionally, this is how we would be resecting those patients. There's sort of like pizza slice where we take all the lymph nodes and we cut the bowel proximally, distally, and then get the mesentery. In this approach, we start with the mesentery because we want to save very small branches that we mentioned. So here are the small branches that we saw in the CT scan that then we save by peeling the tumor off of them. And by doing so, we're able to save some intestinal length. And a lot of things that are deemed unresectable become resectable when you take that approach. So messages do not take unresectable as guaranteed. It all depends on who's the surgeon who said that. Then we look at this liver, and it was previously embolized, but again, there are some spots that have not responded to embolization. That's where I called a friend, and we decided to do some tumor enucleations of the ones that were not responding. And intra-op, they're sort of easy to identify because they're still very hard, whereas the ones that responded become all mushy from the embolization. So we did multiple tumor enucleation for him to remove that disease and get better control long term because we were already in the operating room. So it looks something like that. Now, during the surgery, this is what happened. I hope the video works. Oh yeah, it works. So that's a video courtesy of Dr. Pasika, but the blood pressure dropped suddenly below 90 systolic, and this is the patient's face. So what are we doing now?
I passed the microphone on to her as soon as I saw that.
Well, I mean, she uses drugs that we all know about. I guess I'm showing this like we're an audience of oncologists and surgeons because the preoperative management of those patients is extremely important for what we face in the operating room that directly impacts whether they're going to live or die. So what's going on?
So obviously, we're now dealing with a carcinoid crisis in our room. So as much as I would like to believe that you guys are paying attention to what's going on the other side of the blood-brain barrier, that is not necessarily always possible, and that's understood.
As you can see, surgeons are victimized in the oncology clinic, but also in the operating room.
In the operation. So from our end, all right, the first thing that will occur is that we will tell you what's going on, because what we need at that moment is for you to stop, if you can stop, so that we can try to get some medications on board in order to address the load that we're dealing with now in terms of serotonergic agents that are spreading. Across our monitors, I'm looking at, right, so I'm looking at my hemodynamics. Okay, and with the assumption being that for the most part, I'm dealing with issues in my systemic vascular tone. Okay, the medication of choice to begin with is going to be octreotide. We will bolus it in reasonably significant dosages, usually a minimum of 100 micrograms minimum to start, okay, of bolusing, and we will titrate to effect. That being said, okay, obviously we cannot just dwell on octreotide. If we need to support in other regards, we will. So initially in the context of the crisis, we're gonna aim for addressing the vascular tone component. So we'll move towards agents like phenylephrine, vasopressin for that support. Now the problem is the next thing I'm going to be looking at is my ventilatory status, right? And the risk of the fact that we've now gone into bronchospasm, and if I'm now impacting my tidal volumes and such, and therefore potentially my oxygenation, if my airway pressures have gone up tremendously. Okay, so I'm going to aim to hyperventilate as best I can, okay, in order to bring my CO2 down and allow for a respiratory alkalosis, because in particular in this patient with his right-sided heart failure, or not heart failure, but heart disease, okay, I'm going to potentially be impacting that function in the context of this crisis. So I have to remember that it's also going to need to be supported somewhat if I can't get it under control, but it's going to be at the bottom of my list to try to address from an inotropic
And while she
standpoint.
does all that, we're standing there with her twiddling her thumbs and waiting and just wanting to operate again and push on the liver. Surgeon is not good at waiting. That happens. So at the same time as we're going through this is a patient with right-sided heart disease. We're operating on the liver. Now he's received some volume because he became hypotensive. And we have uncontrollable bleeding from the liver because there's too much pressure from the right heart. And so we, long story short, struggled for quite a while. At some point considered just packing the patient and taking him to ICU, trauma style, but eventually got control over it and were able to manage. This is what the anesthesia sheet looked like at the beginning of the case. So you see, like, we start at 8. I don't know when the patient, this is probably induction, I would suspect. And then this is what it looked like when they went into crisis. So like really, really dropped. The anesthetist struggled for, like you can see, about 2 hours here. And then finally, we were able to stabilize the patient. At some point, the issue was that we had to keep operating because the liver was bleeding. So there was no way I was able to not touch the liver. And then an intra-op echo was done. So they called in one of the cardiac anesthesiologists. And it was this SAM thing, which Dr. Ledowski told me what it is yesterday. It's related to HOCM. Is that what it is?
Obviously, in this patient, and they're actually more so worried about, from the intra-op echo, about a left-sided heart issue. And so I don't know if this patient specifically had a diagnosis of underlying hypertrophic cardiomyopathy. It's not necessarily the case. If they had an underlying just hypertrophy of the left ventricle and with reduced loading conditions, okay, in this patient, both from a bleeding perspective, an attempt to reduce maintenance fluids in the operating room, and in addition, a decrease in forward flow into the left ventricle due to the right-sided heart disease. The left ventricle ended up, in this context, underfilled, and with essentially a dynamic obstruction of the left ventricular outflow tract. They're suggesting that essentially the anterior leaflet of the mitral valve got sucked into it, leading to malcoaptation of the valve and mitral regurgitation moving backwards. So systolic anterior motion of the mitral valve.
And that's when you figured this out, that they were able to stabilize the patient. So I'm showing this because those are a very complex situation, lots of moving pieces. The pre-op assessment is important, the pre-op preparation and the careful planning of the different steps in the care are crucial, but also making sure that we have the expertise, not only from an oncology perspective, but everybody who's involved in the room. And I wouldn't do those cases outside of a center that has ability for cardiac surgery for somebody to come into the OR and echo intraoperatively. And so this is what the patient looked like at the end. I put on Dr. Pasika's patient over mine. But pretty impressive. The interesting part is, like, I never see that. Because I'm over there. I'm over here. This I don't see, so I was quite impressed when I saw the video. So this patient, after surgery, went on to continue on SSA. His 5-HIE was reduced even further, like, for what it's worth, because there is variation in measurement. Went back to his racing. Was very, very happy. That was very important for him. At 2 years, 5-HIE started going up. The flushing recurred. The liver disease progressed, so we had a repeat embolization. His heart disease progressed. And eventually, at 2.5 years, he went on to have cardiac surgery and had double valve replacement with Dr. Cohen. And he survived. Now he's 7 years. He's still alive post-presentation. I just noticed that we have a multidisciplinary clinic, and during COVID, we couldn't do that in person, so patients were sort of separated in our different clinics for follow-up. And I lost touch with him, and I just realized because he was followed by Dr. Law, who saw him this summer. So he's still around. And so, last question about the zebra. What's the number one predator of zebras? Do not say the oncologist. I mean, we are hunting them down. Yeah, lions. Lions. All right, so I just, this was what I wanted to talk about, like, highlight the important thing about carcinoid heart disease and how complex of an issue that can be. There's lots of different moving pieces, from endocrine control to tumor control, the careful planning of surgery and the sequence of that, the cardiac assessment and having dedicated cardiologists, also dedicated anesthesiologists who have knowledge in heart disease, intra-op echo, and also carcinoid management. Yeah, and that's one of our patient, the first patient I presented, who told his story publicly, so that's why I can present him here. But just wanted to, he passed away a few years ago, wanted to give a thought to him. Thank you.
Okay, Julie, thank you. Fascinating two cases, and I'm sure there's times during the day you say, what would Celine do right now? All right, so we are right on time. It's 10:15, and now we're going to have our first report on a research grant. So over the next 15 minutes, and then we'll have break. So Dr. Merlin, thank you so much, and happy to have you here.
Is it working? Yes. Good morning, everyone. My name is Marine Merlin, and I'm a PhD student under the co-supervision of Dr. Shah and Dr. Beauregard here at Quebec City and Université Laval. Thank you for allowing me to present our work here. So our lab was granted with multiple grants from CNETS over the last few years to support our work, our preclinical research on improving neuroendocrine tumor treatment. We mainly focused on peptide receptor radionuclide therapy, or PRT, and I might also call it LUTAT in this presentation. And quickly, just for, I think you know, but it's a somatostatin analog linked to a radionuclide that will do DNA damage through the radiation and hopefully lead to apoptosis of cancerous cells. And our work is to find a way to improve PRT. So one of our ideas is to target DNA damage that occur after the radiation. And we tried by using an inhibitor of PARP1, which is a protein involved in DNA repair. In our paper published in 2018, we show that the combination of PRT with inhibitor of PARP leads to a decreased cell viability in net cell monolayer, as well as a decrease in volume in spheroid nets. PRT is based on the principle that there is somatostatin receptor on the membrane of cell nets. And our second idea is to target this receptor to upregulate them. To do so, we used a subtoxic dose of chemotherapy. Here we use temozolomide or TMZ. And we found that on bone cells which are pancreatic net cells, we found that this subtoxic doses of TMZ lead to SSTR upregulation that is time and dose dependent. And you can see on this Western that show the SSTR protein as well as all the post-translationy modified version that either a short treatment of TMZ or a continuous treatment of TMZ lead to the same results. After looking at the SSTR2 protein expression, we look at the mRNA expression, and we found also that there is a TMZ-induced selective upregulation of SSTR2 mRNA among the other 5 SSTR. Just to point that SSTR4 is not here because the level was so low that it was not detectable by quantitative RT-PCR in this cell line. And so this subtoxic doses of chemotherapy upregulate SSTR2, which results in increased uptake of lutats in the cells and results in a greater therapeutic effect in the cells that receive TMZ followed by PRRT compared to the one with the treatment alone, either chemotherapy or lutat. So this is an in vitro level. The next step was to go in vivo. So to do that, we used immunodeficient mice that were injected subcutaneously with bone cells on the shoulder, as we can see here on the PET scan. So the mice receive either TMZ by IP injection for 5 days or DMSO as a control for 5 days. On day 7, they receive an injection of gallium DOTA octreotate, and they were sacrificed to be proceeded through biodistribution study where we measure the percentage of injected dose per gram. And here we have the tumor to organ ratio, and we can see the results show that there is a higher gallium uptake in tumor than in liver with 5-day treatment of TMZ compared to control, which is an interesting point because the captation, greater captation to tumor versus liver is one of the criteria for patients to be allowed in PRT treatment. So half of the tumor was used for this biodistribution study. The second half was used to do RT-PCR that we have here with the quantification on the side. And we can see that there is also an upregulation of SSTR in this net cell line-derived tumor, especially SSTR2 and 5, which is also good because they are the main target of octreotate, the somatostatin analog used in PRRT here. As you might know, there is a very limited availability of net cell line to do preclinical study. So to validate our hypothesis on a more diverse net sample, we thought that we will use biopsy from patient sample in an ex vivo model. To do so, we just we first confirmed this model in a bone 1 tumor made in mouse. So the tumor was collected and then put in cell culture. Because our cell line is transfected with luciferase, we were able to do luciferase assay, which is an ATP-dependent reaction. So that means that if there is a signal, there is ATP, and it means that there is an active metabolism, which means that the cells are alive. So here you have a bioluminescence imaging of the tumor in mice that you can see again here in cell culture, and we have a signal up to day 15, which means that this model can be used for our experiments. So the pieces were treated either with DMSO as a control or with temozolomide as a chemotherapy. And the sample were again proceed to quantitative RT-PCR. And we found that there is also a TMZ-induced upregulation of SSTR mRNA here with the blue line. So that shows that our ex vivo model gives the same result, is representative of what we found in vivo. So what's next? Then we want to biopsy sample from patient. This is our latest project in collaboration with Philippe Jobert from UCPQ, as well as a biobank from the research center. We got the ethical approval to collect the sample, and we are moving forward to collect also gastroenteropancreatic net biopsy with the collaboration with Dr. Isabelle Dehé. And for now, we got 3 lung net biopsy sample. And here is a sneak peek of our first results. So we can see that in healthy tissue, lung tissue, the TMZ treatment doesn't lead to any upregulation of SSTR2, while in our first tumor sample of patient, TMZ show a upregulation. TMZ lead to a upregulation of SSTR2, either starting at day 4 or slightly delay and starting at day 7. So now we are looking forward during the next year to continue to collect sample and to improve and validate more these results. Thank you for your attention. It's collecting more sample to validate this because this is still preliminary data. It's just 2 samples of lung nets, and we want to extend to other type of neuroendocrine. But then, of course, next step will be clinical trial, hopefully.
Yeah, it'd be interesting to see how long that upregulation happens.
Yeah.
In terms of sort of a run-in with temozolomide, right? How long you need to give it before? That might be a question you want to explore.
So we did it from the in vitro work. Meredith, you want to answer that question, or otherwise?
Yeah.
Treatment 5 days before.
Yeah.
So 1 week you do the TMZ treatment for the cells, and next week you get the upregulation.
Yeah.
So this is we are aiming in such a way that it is feasible in clinic.
Yeah, exactly.
And so that is the model we are modeling over study.
Merci. Thank you for the presentation, Mr. Mapet from Julia. Are you looking for any retrospective correlation between the response and the side effects, the complication by combining temozolomide with the DRT, especially for myelodysplastic syndrome? Could we, this would be an important question for the clinical outcomes.
We didn't, like for toxicity thing, we were thinking that there is CAPTAIN and PRT combined clinical trial going on. And the first study showed that there is none to little toxicity resulting from this combination. So we can think that if we use lower concentration of only temozolomide, it should not at least result to the higher toxicity than the combination of CAPTAIN and PRT. This is this patient, mainly naive from any treatment. Like surgery was the main, the first, or one of the first treatment that they got. And because they're not doing the biopsy for us, they're doing them, like we're just getting the treatment for biopsy. So we cannot really ask for other medical. Right.
unless CNETs would give us money like this, we would never be able to go back and say, yes, they survived, yes, we had ethics approval, we have done 20 patients and it works. And the whole idea is that if this can work ex vivo for this tumor, then for any tumor, and therefore we are very happy that other surgeons have agreed to collaborate with us. But it's a classic example of how you can exploit our grant program to do something way more than what you would otherwise be able to do. Thanks.
Thanks so much. Super, super interesting. And I just think another kind of clinical comment would be you'll be discussing to correlate that with findings on functional imaging in terms of avidity on like octreotide or gallium, like as a somatostatin receptor imaging to kind of see, what changes could happen post-treatment, through certain.
I'm not sure I understand the question.
Okay, so maybe I can answer the
Yeah,
question. So this is with the biobank of IUCPT, the Lung and Heart Institute of Quebec City, and they have all the data. Right now, we are all working in blind. We don't know which patient it is. We just know which neuroenhancer it is. And I'm hoping that they will have done this work before and after. So when we write down the report, I'm sure that this will come. But it's a very good point. We have it with them.
Yeah. The only data that we have now is if they get chemotherapy before or not.
Yeah. This was the exclusion criteria,
Yeah.
that for previous 3 months, hopefully they haven't had chemo, so there is no contaminatory process.
Okay, and I think there's one more question in the back, and then we'll move to break.
So I guess what I wanted to know, in the case of patients, the CCR4 is expressed homogeneously, and what would be more important to increase the level? So if you have cells that don't express it at all, right? So probably those are going to be the escapers at the end, and those are going to be the ones that are going to relapse. Do we know anything about the expression of these cells?
Maybe once again I can intervene, but what we find in our in vitro studies with cells which were having different level of SSTR expression, we found that the ones which were low stimulated very highly comparatively. Say for if they were 1, they will become almost 5 or 12. Those which were high expressor went from 1 to 2.5 or 3. So we are hoping that this will work for both. What would be otherwise treated as a negative for indication for PRRT would now become positive for PRRT. But this has to be done. We have no idea whether the clinic is actually, the surgery side has done this or not. They're just telling us that they know it is neuroendocrine tumor and therefore they're giving us the sample in blind. So we do not know what is the original status. We do qPCR for SSTR2 and 5, where all the SSTRs we have, and that's it. So it will be very interesting to study double blind like this, and we are just open to the possibility that whatever comes out, we don't know.
Okay, thank you. So great stimulation of conversation, and we can move that into the break as well. So break now for 15 minutes, so till 10:45, and then Sen is going to have a talk and then another panel discussion before lunch. Thank you.
Hi. Hi. Okay, welcome back, everybody, from your break. Okay. A sign of a good meeting is all the conversations going on. Welcome back. My name is Calvin Law. I'm one of the surgical oncologists, and I'm just Julie Halle's sidekick. Okay. So we've got a great session ahead that's a little bit of a combination of anything that starts with P. So it is peptide receptor radiotherapy and pancreatic neuroendocrine tumors. And I think this is going to demonstrate some of the amazing sort of variations in neuroendocrine tumor, which requires a team-based approach. We've got a great panel coming up, and I'm going to ask them to introduce themselves when they get there, one at a time. I also love, Rachel and I love being the penultimate talk before lunch because just to point out that only Simran will be preventing you from eating. Okay. On that note, we're going to get started first with Dr. Marhag, and he's going to give us an update on PRT and radiotherapy. I think there's a research grant associated with this that you're going to update us on. Thank you. But not this talk. Okay. I'll just wing it. Wing it. Okay, sorry. That's what it said here.
That was going to get ugly really fast. So I just want to say, in context of what Dr. Ahmed was saying before, in the immortal words of my colleague David Laidley, the heart is the vector in which PRT is delivered. And so I think that's why we know it's so important to deal with carcinoid heart disease. CNET's 2022. There we go. Fantastic. All right, so I was tasked to do 3 things in 15 minutes, so it's going to be a little bit of a whirlwind tour. It was to focus on PNETs and discuss the role or the impact of PRT, and then move into what is the role of radiotherapy in the management of this disease, and on top of that, talk about a research grant. So that's going to be really the focus of the talk, and I'm hoping to get through all of it in 15 minutes. And these are my disclosures, and I do need to thank Novartis AAA, Ipsen, and again, CNETs for sponsorship for some of the work that's going to be discussed today. So again, we're going to talk about some of the current data regarding PRT for pancreatic neuroendocrine tumors and look at some of the potential trials and options that are going to lead out of some preliminary work that's been done. So what is the current status of PRT in Canada? And we know it's geographically varied. It depends very much on what province you live in and what the funding structures look like. But in my home province of Ontario, right now, the only funded indication is for midgut tumors. And so this has left us with inequalities across the country with respect to access for this treatment. But there have been some updates with respect to data supporting this indication, the first being published this year, the NETTER-R study. Now, this is a retrospective real-world evaluation of the use of PRT for pancreas neuroendocrine tumors. So of that, 110 patients were evaluated. The majority received the standard 4 doses of 200 millicurie. In those in which they were available for tumor response, the median progression-free survival was over 2 years with an overall response of 40, which is pretty dramatic when you compare broadly against midgut tumors. In all patients treated, so not just those that were available for response, the median overall survival was 41 months. So pretty significant data for this patient population. You know, again, we need to put it in context that this is, of course, retrospective, but this is real-world data. Further, there was a report at ESMO of the oculorandom trial. So this was a phase 2 study comparing PRT versus sunitinib for unresectable and metastatic PNETs. So 84 patients were studied, and again, you can see from the results to the side that The median progression-free survival for those patients treated with PRT was almost 21 months versus 11 with sunitinib, which is in keeping with what we know from prior trials. And the toxicity profile, interestingly, was less in the PRT arm. So based upon this data, PRT, and also based upon a lot of the work from people in this room from an advocacy basis, it has now been approved by PCODER. And so I think this is a tremendous advance for patient access across the country. And I think it's something that all of the advocates here can be proud of. And so this is the first step for funded care. And I think this is important to know that this is really a landmark in terms of improving access for patients. I do want to put a point of caution, and this is going to be really relevant to our population because we haven't had this access. And so patients, if you're deciding, are you going to get PRT or CAPTEM, there is concern about the synergistic effect of these two therapies. This was presented at NANETS last week from the group at Moffitt. Again, admittedly small subset of patients, but those that were treated with CAPTEM either before or after PRT. When we look at most of the data regarding MDS or leukemia, it's generally in the range of 2%. When they looked at this patient cohort, that was 10%. And so it is something that is pause for thought, I think, for all of us that are looking for proper patient selection, proper sequencing of patients, that we need to keep this in mind, that this is a real risk, and this is something that I suspect as more data becomes available, we're going to see a continuation of these kind of numbers. And so again, really behooves our discipline to continue to work on proper sequencing for best patient care. So what's exciting or what's on the landscape for pancreas neuroendocrine tumors? I know Simran will talk about this more in depth later, but the NETTER-2 study, which is an international randomized controlled trial of patients with newly diagnosed grade 2-3 GEP-NET, so this includes pancreas patients, has finished its accrual. And so we are now waiting for the trial to read out to occur. So that's really exciting. And again, we have a lot of investigators in this room that were involved in the study. So the Canadian contingent of this was excellent. From a North American perspective, the Alliance study led by Tim Hobday is looking at CAPTEM versus PRT. I think this is an important question, and again, it is something that is grappled with in the clinic, and so this is currently accruing in the United States. And then finally, again, in the Canadian landscape is the Action 1 study. So this is a phase 1b/3 randomized controlled trial, and this is looking at actinium-225. This is an alpha emitter. So this is actinium-225 versus standard of care for patients who have progressed, who have already been treated with standard dose PRT. And so it's addressing not only a novel isotope, but it's also addressing the issue about retreatment. And so again, these are, I think, important studies coming across the Canadian landscape, and there will be multiple centers, again, across the country that will be enrolling to Action 1. So my main disclosure is that I am a radiation oncologist who firmly believes in radiation oncology for the management of this disease. But we know to date that the data has been very, very limited. It's really been relegated to small series, retrospective reviews, and pooled multi-institutional data. And to that, I was part of the recent NANETS guideline looking at the role of radiotherapy for treatment of grade 2-3 neuroendocrine neoplasms. And the truth is there was no consensus on the role because the data is so limited. And so you can imagine a room where you've got 2 radiation oncologists and 20 medical oncologists and 5 nuclear medicine people, that we got voted down quite vociferously. So what it tells me is that we need modern data. We need to really evaluate modern radiation treatments and techniques to better understand its impact on this disease. So I am an SBRTer, stereotactic body radiation, or SABR as it's otherwise known. This is high-dose, highly conformal radiotherapy, and the concept is you're overcoming the biologic issues surrounding radio-resistant disease. And we've got emerging retrospective as well as prospective data for both primary and metastatic neuroendocrine. So this is our data that was published this year. This was our review of 40 patients with 53 neuroendocrine liver metastases treated with SBRT. The response rate was 32%, which again is in line with data from colorectal liver metastases, which would be the baseline that we would compare SBRT. But I think importantly, we see very good local control, so 93% at 1 year, and our level of grade 3/4 toxicity was 0. So, admittedly, this is retrospective, but it is, again, proof of concept that this is an idea worth studying. Further, we did a prospective trial where we looked at oligoprogressive disease in combination with everolimus. This was also published this year in ERC, and this was 40 liver metastases treated with concurrent radiation and everolimus. And as you can see from below, overall response, 38%. 1-year local control of treated metastases was 97%, with a median PFS of 12 months. Now, what's important to note about this study was these were patients that were progressing on standard line therapy. They were given radiation, generally anywhere from 3 to 10 doses, with everolimus at that time and then followed thereafter. And so the progression-free survival is really related to the upfront treatment as opposed to subsequent maintenance therapy. But it's not just the liver that is impacted. That a group in UCSF looked at sites across the body, primary and metastatic, also including high-grade disease. And what they found was a 2-year local control of 98% with a response of 68. So again, small series, but proof of concept of the idea. So where are we going? And this is what has led to our SaberNet trial. So this is a prospective study of patients treated with SBRT to any site. So this is primary symptomatic metastatic or oligometastatic oligoprogressive disease, in which we're looking at local control and PFS. There's a correlate to this, and this is where it ties into the CNETs. That in 2018, we got a grant from CNETs to evaluate radiotherapy to extend immunotherapy. There's a long story that goes with this, and that this was being leveraged to an industry partner, which Simran can tell you later, ultimately pulled out of the trial. And so with everything in this era, we had to pivot, and we went back to CNETs to look at if we could get correlative data. So can we provide some primary pilot study to support this concept? And so it was brought back to the CNET's advisory board, and it was agreed to move forward with this study. So further to that, and again, grateful to partners involved with this, that this was trial workshop evaluated at the ComNet's 2018 meeting. And this was felt to be high priority, and they also felt that pilot data was needed to support the broad rollout. So we were planned to enroll early 2020, and then something happened in the world, and it changed everything. And all clinical trials were put on hold, and we had to wait until we were at a steady state, both in terms of hospital capacity as well as our clinic, to move forward. And so I'm happy to say that SaberNet has now opened. We were able to open January 2022, and of the 15 patients for the correlative study, we have enrolled 10. So we're 2/3 of the way through. And so we're hoping to finish our accrual within hopefully the next 3 to 6 months. So what are we looking at? So the correlative study is evaluating serum and plasma at 4 time points. So we're looking at baseline, during treatment, at 1 month and 3 months post SBRT. And this is work in collaboration with my colleague, Dr. Stan Liu, at the Odette, who's going to be doing flow, as well as colleagues at the NIH, who are going to be doing the multiplex cytokine array. And so we're trying to understand whether or not the addition of SBRT will influence the expression of these markers, potentially showing a role for upregulation of the immune system. Additionally, my colleague Dr. Huang, who's in the room, is going to be doing pathologic evaluation of the tumoral and microtumor environment for expression of PD-L1, CD4, 8, and FOXP3, again, to understand whether or not baseline these tumors have marker expression and whether or not they can be, or if we can alter their expression and function. Now I want to come full circle. So we talked at the beginning about PRT, and now I want to talk about PRT and radiotherapy. So we know that this is a highly effective therapy for patients with early stage disease. This is demonstrated by NETTER-1 and really has become standard of care. but we also know that this is an incredibly heterogeneous disease. And there are reasons why perhaps our standard therapies are not effective. And so part of it, we're waiting for NETTER-2 to understand what happens with a higher grade disease. But I think that there is a role and opportunity that can we address this heterogeneity within patients to improve their outcome. Colleague David Chan, who was our former fellow who is in Australia, have developed the NET-PET prognostic scheme, where they're using FDG and somatostatin imaging to determine those patients that would best benefit from PRT. And there is a role where perhaps we can extend PRT to patients that have limited FDG expression. And so what was proposed, and this has been proposed at the NCI CTPM, was that this separate subclonal population will have an ultimate impact on treatment, and can we address those areas of predicted to be less responsive without additive toxicity? And the proposal was that we could deliver SBRT to sites of FDG avidity to extend this treatment. So the schema that was proposed was for patients with progressive grade 2-3 disease with stratification based upon grade to either receiving standards PRT versus PRT followed by SBRT to sites of FDG avidity. And this would be an example of what patient selection would look like, where you've got areas of gallium-68 avid disease, but low volume that doesn't, or that would also have FDG avidity. So as mentioned, this has been presented at CTPM and has been identified as a concept of interest. It is currently being developed through the NCI working group, and the main feedback was that further pilot data needs to be done, not surprisingly. And so this is actually going to be discussed at our upcoming ComNets meeting to determine whether or not there is appetite and ability to do proof of concept study for this. So, in summary, I think we're getting to an exciting phase for pancreas treatments, that PRT hopefully will become part of our treatment landscape in the near future across the country to avoid these treatment funding gaps. And I think what's really cool is that we've got a lot of Canadian centers that are doing a lot of work looking at this. And really, I hope that we can improve opportunities for patients to receive care or certainly expand upon the current standard of care that they're receiving. Thank you very much.
Sure. So we welcome Dr. Meyer-Hogg to the panel, and there'll be more to come. Next, we're going to ask our good friend from London Health Sciences Centre, Dr. David Laidley, and his colleague, Dr. Alireza Khatami, to come up.
So thanks for the invitation. It's my pleasure to share with you some of our PRT maintenance data. We have a couple publications that we're going to hopefully go through quickly here, and hopefully at the end we may have some questions. Just some disclosures here. So the objective of our safety study, which started, I can't even remember when it started, it seems so long ago now, but it was kind of in the era where we didn't really have access to PRT easily. So after SAP shut down for Health Canada, this was a trial that was started in London and sort of in combination with Edmonton with Sandy McEwen. So the objective was to look at the efficacy of lutetium therapy in patients who had induction therapy and up to 8 maintenance therapies, which were given at intervals of every 6 months. And the secondary objectives were to look at safety. So just as I'll kind of skip through this, you don't need to see the inclusion exclusion. So basically the schema was 4 induction therapies, very similar to the NETTER-1, except the doses are a little bit smaller. You can see here that we're treating at 75 to 150 rather than the usual 200. And then we did up to 8 maintenance therapies between 50 and 100 millicuries every 6 months or so. We did a lot of blood work for patients, which obviously they were not happy about, but I think based on our data, we can safely say that we don't need to do that much. This is the dosing schema, so we did adjust the doses based on some factors, which I have here. So it was kind of a poor man's dosimetry. It's not quite as advanced as Jean Mathieu's dosimetry, but this was sort of our dosing schema. We had up to 343 patients at the time of publication. We treated patients mainly in Ontario, but we did have patients from New Brunswick and some patients from Saskatchewan, Manitoba. And in terms of Ontario, we had predominantly patients in the London area and then treated patients in the GTA and Ottawa region. Primarily looking at the patient population, it was predominantly GI and PNETs, but we did treat a number of other neuroendocrine tumor sites, and again, a kind of a mix between G1 and G2. Most patients tolerated therapy well and were able to complete at least the four induction therapies. So I'll just run through sort of our efficacy data, which was published a few years ago. These are just the waterfall plots looking at RECIST changes. We also did look at CHOI as well, but that's a little bit more complicated, and I think given the amount of work it takes to do those, I don't want to ever do those again. So looking at our PFS, this is looking at our progression-free survival for our entire patient cohort, and our median PFS was 36.1 months, which is, I think, very excellent. At the time of our original analysis, we hadn't met our median overall survival, although on updated review of our data, we now have a median OS of our entire Group A patients or PRT naive patients at 78.2 months. We looked at differences in time to progression for G1 and G2, and there really wasn't any significant differences in the time to progression in G1 versus G2. There really wasn't any differences in survival of G1 and G2, and we had looking at median 44.8 and 45.6, so very, very comparable. When we looked at overall survival, there was a bit of an overall survival benefit in patients that presented with midgut rather than pancreatic. So generally, I think probably that's in keeping with midguts being less aggressive than from PNETs. And then we also kind of analyzed to see whether there were differences in like regional differences, whether patients being treated at other centers maybe were coming to our program with different sequencing of treatments, different state of their disease, and there really wasn't any significant difference in the outcomes of those patients when we looked at London versus outside. So that survival and PFS were similar. So caveats, one thing that we did learn, tumor delineation, I've showed this before. This is a patient with, conventional neuroendocrine tumors. If you ask your radiologist, I've shown this before, where do you measure your tumors? Is it here? Is it here? This is the functional imaging showing the tumors are kind of in between and, some here. So in terms of looking at measurements of these tumors, I don't know if any of you guys have done it. It's exceedingly difficult for neuroendocrine disease. Prostate's much easier. For neuroendocrine disease, just given the mix of tumor necrosis, cystic changes, differences in enhancements at portal venous and arterial phases. I think measurement of tumors in neuroendocrine tumors is exceedingly difficult, and I think for all clinical trials, I'm sure there may be a missing piece in terms of what we're measuring. We sort of measure what we think is the tumors on CT, and I think in many cases, I think we're probably not measuring the right thing, but there may be better ways to do it. So just some thoughts on efficacy. In terms of our overall data between our midgut, PNET, and others, very effective therapy. One thing that our trial did not allow for was retreatment of patients who had excellent responses. So we do wonder, in terms of our dosing scheme, maybe we underdosed or overdosed certain patients. So maybe there is some role for dosimetry and maybe some role for maintenance. And I think there are some limitations in using anatomical imaging for assessment of neuroendocrine tumors. And I'll just move on to let Dr. Katami go through the safety data.
So thank you for introduction. So I went through the toxicity part of this study. It's not necessary because the toxicity of lutetium is almost recognized, but because we did this research as part of the registry, I have to do this toxicity data. So basically, we have 52 patients that included in the study. During the first cycle, 3 patients was withdrawn because of the impairment in the mental, and also one of the patients withdrew the consent. After the second cycle, another 3 patients withdraw again because of the concerning about the cognitive issues, and one of the patients actually is withdraw the consent. So basically, we have 46 patients that completed this trial. I did the evaluation for cumulative activity that we gave to the patient because we have the dose modulation. As we can see here, patient with PNET received more doses compared to the small bowel, which is predictable because this patient had the less symptoms that they can tolerate more doses during the 4 cycles. But patient with the metastatic small bowel, they have the more volume of the tumor in the liver that we need to adjust the dose because of some toxicity that we saw during this test. But overall cumulative dose that we had is mean is about 19.6 gigabecquerel, but is range from 3.8 to 22.2 gigabecquerel, depend on the patient that received just only 1 cycle or 4 cycle. And this plot shows the number of doses that our patient received and the modulation that we gave to the patient. For example, patient number 1 started with the lower dose because of some toxicity that the patient had at the baseline, but during the therapy, patient behaved better and we gave more dose. But patient, for example, number 51 started with full dose, and then we have to reduce the dose because of some mild toxicity that we saw. So in overall, what I would say, we didn't have any grade 3, grade 4 toxicity that need patient to be hospitalized or withdraw from the study because of this toxicity. But based on this table, if you look at the, if you look at the bottom one, any type of adverse event from the hematological perspective, 83% of our participants had some adverse event at the baseline, but at the level of grade 1 or grade 2, because for sure we didn't include grade 3 or grade 4 in the study. But after 4 cycles of treatment, we have 98%. So we have more side effect, but at the level of 1 or 2 adverse event during our clinical study. And from the symptoms, also the patient had about 81% of patient had some sort of the symptoms like weight loss, diarrhea, flushing, and it's also increased in 96%, which is expected because we give the radiation to patient, and for sure some of these patients may have some sort of problem. But one thing that was interesting, some of the symptoms actually relieved during this therapy, and some of the symptoms shows more compared to the baseline. But the differences between these changes wasn't significant. And we did a comparison with the NETR trials because we did the dose modulation compared to the fixed dose. So basically, what we can notice, there are some increase, some reduced compared to NETR trials, but overall we have comparable toxicity, mild toxicity level 1 or level 2 throughout this study with no significant change. So this is another table that we compared the cumulative dose from the other available data at the time to ours. So I reviewed 8 clinical trials. We stood at the middle from the size of the cases that we had. We had 52, the other studies some more, some less. But our cumulative dose was almost lower than all of them. And we had the same efficacy as Dr. Lady mentioned. Regarding the toxicity, we barely had any toxicity. So we have 0 level 3, grade 3 or grade 4 toxicity. We had one patient that had some kind of increased creatinine, but this patient wasn't related to our group of patients. This patient had mass on the pelvis that caused urinary blockage, which is not related to PRRT. Otherwise, we didn't have any grade 3 or grade 4 side effects like myelodysplastic syndrome or anemia that was seen in other study like NETRS trial. And so this is a sample of the highest changes that we noticed during our study. For example, we had more changes in liver enzyme, which is expected because we had patients with huge or large volume of liver metastasis when they included in this study. So basically, this patient may have some changes in the liver enzyme, but even with this high, almost 3.5 times increase in the liver enzyme, this still is the category of 1 or 2 of the side effects. So none of these changes actually change the grading of the adverse event from the 1 or 2 to 3 or 4. And so basically, based on the safety data, we didn't have any significant renal toxicity. The one that I discussed about the increased creatinine is related to the mass, not from the PRRT. And in the arm, group A is actually the patient that were PRRT naive, 52 patient that I mentioned. We didn't have any myelodysplastic syndrome. We had one patient in the group that we treated with the history of treated with PRRT in the past. One patient had the myelodysplastic syndrome, but that particular patient already received radiotherapy and chemotherapy as well. So we exactly don't know that the myelodysplastic is related to PRRT or because of the combination with other toxic agents. And we didn't have any grade 3 and grade 4 toxicity. So whether it's because of the lower radiation dose or because of the indication that we impose to adjust the dose in this patient, we don't know exactly. And so another study that's done with another member of our team, Dr. Suiha, which we went through the survival predictor of our patients. And we found that from our patient, the patient that shows more liver involvement, more than 50% of liver involvement, and also more bone metastasis, more than 5, this patient behave bad compared to the patient that doesn't have this. And also if the chromogranin level is increased by 4 times, and also if the patient had some kind of ascites at the baseline or during the therapy, this patient also shows a poor outcome. And this is the this is the diagram that shows the overall survival of this analysis. And as you can see, the patient with gastroenteropancreatic cancer behave better, and the patient that are not originally cancer from the gastroenteropancreatic behave worse, bone metastasis, and also ascites has a poor outcome in this category of patient, and p-value shows here significantly is very significant. And yeah, these are the same definition that I mentioned. And regarding the progression-free survival, again, the same category patient with the more chromogranin, pre-existing ascites, and also with the metastasis outside of the regular location, which is outside of the liver, lung, or peritoneum. This patient behave badly. And the p-value were significant as well. Okay.
I just have just 1 or 2 quick slides on some data that we kind of just recently tried to review. So, you know, we often think that having good responses is great, and we've had patients that have had really good objective response rates with PRT, but we have been noticing between our safety study and the osmosis trial that some of the patients that actually have really good responses, sometimes the longer-term outcomes for these patients seems to be less favorable. So we went back and reviewed our data, and we looked at the PFS for patients who had greater than 50% response after 4 cycles, so patients who were either stable or responders. Any patient that progressed, obviously, we excluded them, but it's not statistically significant, but we only have 5 patients in the 50% or higher at 12 months, but we did, we did observe that the median PFS for those really rapid responders was only 25 months, whereas the other patients that were stable or up to 49% had almost, less than double the PFS. So, this is something where I've been seeing it more and more. The longer I've been doing this, you have those few patients that are really excellent responders, and it's making me wonder, after we complete our 4 cycles of Lutathera or PRT, are these patients, they be treated differently than the stable patients or the mild responders? And whether we need to consolidate that with further PRT or whether we need to combine that with some other therapy. I think it's an area where I think it might be interesting to explore that possibility. So I think the median PFS separation here, while not significant, is sort of tending to suggest that there is something different here. And I just want to acknowledge Dr. Reed, who retired a couple of years ago during COVID. So this was originally his study, which I took over, and obviously Dr. McEwen, who was also one of the developers of the original protocol, and everyone else on the team. Thanks very much.
Thank you so much. Lots to learn. Okay. Now, moving forward, we have our panel. I'm going to invite Dr. Goodwin to lead a case presentation. And if the members of the panel could come up, Dr. Marhog's up there, Dr. Wang, Dr. Lemelin, Dr. Simoneau as well, if we can come up. Sure. Okay, sorry. As you can tell, I'm just keep pushing on here.
Okay, so clearly a hot topic. So I'm also wanted to mention that the CNETS group would like to have a photo before lunch, so right after Simran finishes speaking, if we could all gather up here very quickly, because it's been a while since we've been together. So, yeah, all the attendees. Yep, exactly. Okay. So you can see the panel members. Thank you. So this is a case that's kind of going to go over some decision points, but also I think some standard of care issues that come up with neuroendocrine tumors and supportive care issues that come up. And of course, like any case, sometimes we don't know the right answer. Sometimes it brings up more questions and sort of in the tail. So who is this? Julie put up her favorite artist. Who knows this guy? I'm from the Maritimes. Tom and Tom. Do you notice that he's a sleeping zebra? He has the leg up. So there we go. Yeah, there we go. Yeah, and he is from the Maritimes, grew up in St. John. Okay, so Julie has less words, and she likes to cut. I don't cut, I have more words. So I have been noticed. This is a theme with us. Okay, so this gentleman, he presented in December of 2017, 70-year-old gentleman, had flu-like symptoms, went to his GP. Hemoglobin showed that it was low, 79. Had a tonsillectomy before, BPH, some BPH medications, no family history of cancer. He had a recent colonoscopy, so that was not repeated. He did have an upper scope, and it showed invasion into the stomach, the likely source of bleeding. And the patient actually says, oh yes, actually on and off, I've had melena, black stools. And the path shows a submucosal neoplasm with oncogenic features, but the fragments were too small for a diagnosis. So we do an exam. He actually looks very well. He's a bit pale, but he actually looks quite well. ECOG 1 and some mild left upper quadrant pain. We do a thorough review of symptoms. We cannot find any hormone symptoms, so we're labeling him as non-functional. And we also do his glucose, and that's normal, and there's no history of glucose derangement. So he's given a transfusion and put on a PPI. So here is, like the surgeon, I couldn't trust myself to put the dynamics in here, so I did cut and paste. What do we have here? We have an infiltrative large mass at the tail of the pancreas. It's large, it's 13 centimeters, extension into the spleen, multiple liver mets, and multiple perisplenic lymph nodes. We do his chromogranin, it's 415. His urine for 5-HIAA is normal. To the panel, are you still following chromogranin? No. So many of the guidelines are coming out that it may make more confusion than good, especially when they're on a PPI. And is this values endocrinology? Would this be in keeping 415 with being on a PPI in terms of a chromogranin level?
With the patient on PPI, sometimes I still follow the chromogranin A, but I know it's not really important. We still need all the CT and MRI to make sure that everything is stable. Mm-hmm. But for now, I know the many guidelines question if we need to follow the chromogranin A. Especially in patients with PPI or other medication that can make not reliable the level of chromogranin A. So sometimes I do it, but I just make sure that I have everything other things to make sure I can make a right decision for the patient.
Okay, so it certainly doesn't eliminate, or it's not the main factor that you make decisions on. Okay. So he goes to multidisciplinary tumor boards, and yes, they describe an extremely large tail of the pancreas lesion. They actually describe a tumor thrombus that extends from the splenic vein to the main portal vein and multiple liver mets. And say at this point, the systemic treatment is his course. Okay, pathology did not show up. This is going to be interesting. Okay, so the report is supposed to be showing up, and now it's not. So are you happy with this report? So basically, the report states that this is a pancreatic neuroendocrine tumor. The Ki-67 is 10%. in keeping with, it was a liver biopsy, by the way, in keeping with a neuroendocrine tumor. And question for Dr. Hang, do you think we should routinely be staining for hormone status as well on the tumor if they're asymptomatic?
Well, it has never been my practice to routinely stain hormone on the tumor for a variety of reasons, because the stain come from IHC may not correlate with the hormone level clinically. And the other thing is the issue of IHC, right? If you have non-validated markers, and you can potentially run into this false negative and false positive results. Yeah.
Okay. Okay. Can I see a show of hands? Who would routinely have hormone staining done on their PNET diagnoses? Okay. we have Sylvia in the background. Hand up. Okay. Yeah, please do. Yeah, go ahead. Yeah.
Which is a breakdown product of serotonin, which is produced by an incrementally small number of pancreatic nests.
Agree.
So why would you measure one hormone which is not likely to be there in a 24-hour urine collection that's a pain in the ass for the patient, when for less money and less work, the pathologist can actually stain for the hormones and tell you what you should measure?
Okay.
Maybe nothing, but maybe there's something there to measure.
Yeah. Yep. Okay. And I guess also moving forward, the likelihood that this patient may become symptomatic. So okay. Yep. Okay. Very good. Good point. All right. So we know that we had this new WHO classification, not so new, it's been in for a little bit, for our 2017 pancreatic neuroendocrine tumors. I've had 2 residents ask me this in the last couple of months, because I'm teaching of this new category, neuroendocrine tumors. They look well differentiated, but they're high grade. And 2 residents have asked me, can pathologists really easily tell a well differentiated high grade from a better behaving neuroendocrine carcinoma? Is that easy to tell?
The short answer is no. It's not easy to tell. Yes.
Okay.
Yep.
Okay.
So we have a couple of markers. We help us sort of more can guide us. Okay, this is likely a G3 neck neuroendocrine carcinoma or a G3 well differentiated neuroendocrine tumor. Yes.
Okay. Okay. And what markers do you like to have in addition?
So for PNET, okay, we have 3 additional markers that we routinely perform in this kind of cases. So one is the RB retinoblastoma. The second one is P53, and the last one is ATRX. And so we routinely perform those 3 markers. So if do you want me to go further to tell about the results? So so unfortunately, so none of the markers are sensitive or specific enough. So still, in the end of the day, you still have this kind of difficult cases. Yeah.
Okay. And are people seeing more well-differentiated grade 3s reported? Yeah. Okay. Sylvia.
I just want to add one more marker, which is SSTR2, which
Okay.
is now in the 2022 WHO average for that.
Okay, interesting. So in that cancer paper, I think we're seeing a theme of we need some updates on markers for tumors. So it'll be a good chapter of that. Okay, good. So sorry guys, this was beautifully before, but anyway, so essentially, Stan, the octreotide scan comes back as, at the time, that's all I had was an octreotide scan. And it does show strong uptake in all areas of disease, okay? So all the liver mets, all the primary on the spleen. And we're going to start to be evaluating, hopefully soon, more PNETs for PRRT. In your experience so far, what's the proportion of patients that are homogeneous uptake on your scan of choice? Clearly that's going to be more gallium-68 versus heterogeneous versus essentially no uptake. Are we starting to see a split, and what are the percentages for PNETs?
I can't give you the split per se, but there is Cimarron, again, leading a study of combined FDG and gallium for these patients, and I found that incredibly useful. And we've used it to kind of stratify how we're going to put patients into bins for treatment. So, I would say within the PNET population, certainly there is more heterogeneity. I think that's quite clear, that we're seeing areas of quite significant FDG uptake. And really, from our perspective, looking at treatments, it's going to be the degree. How much, kind of going back to David's NetPet work, is, how do we use that information to guide our care? And, certainly we've got patients with, high avid galliums, and then you do their FDGs and everything lights up as well.
Yeah.
And, we're going to bin those patients very differently than high gallium avid with no FDG or maybe one or two. And so again, it's just reflective of this disease, that it's not just the radiographic, it's not just the pathologic, but it's the functional as well that's important.
Okay. So would the audience agree that this is probably a group where we want to have a gallium and an FDG PET? Yeah, so I'm seeing lots of, especially with a KI of 10%. Okay, so large tail of the pancreas, metastatic pancreatic neuroendocrine tumor, described as non-functional on history, KI 67, 10%, some extrahepatic disease, and ECOG 1. Sten, supportive care is incredibly important. He's bleeding. What's the success in hemostasis for NET patients for bleeding? Is it equal to other solid tumors? What's your thoughts on this?
So no specific data, but we do this not uncommonly. Especially for patients who are bleeding with low hemoglobin, we want to get them on systemic therapy and want to maintain their hemoglobin. So it's not uncommon that we will treat them up front.
Yeah.
Generally, it's going to be dependent on the rapidity of the bleeding, what that drop looks like, whether radiation is appropriate or not versus other more invasive modalities.
Mm-hmm.
We will, in certain poor performance cases, do big single fraction, because we know the higher the dose per fraction, the better the hemostasis is going to be. That said, for these patients, I usually do 10 fraction. And if you look broadly across soft tissue, so you can't just say NETs, but soft tissue, the likelihood of hemostasis following radiation is in the range of about 70%.
Okay, great. And then surgery, any surgical techniques to help with bleeding, or would you describe this case as let's do radiation first and see how that goes?
Yeah, I mean, this patient is not really resectable from an oncological perspective. However, if I understood correctly, there is invasion into the stomach, so that's what's been
That's
bleeding.
what's bleeding, yeah.
Yeah, I can't really think about any surgical technique that would, definitively treat or manage bleeding on by leaving the tumor in situ, by not doing like a palliative resection or for acute bleeding,
Okay.
which would still be an extensive resection.
Okay.
Whether there's possibility with splenic artery embolization, depending on the localization of the tumor and what vessels are feeding it, could potentially be an option, keeping in mind the
point,
potential risks as well
Yeah.
of that.
Now, sometimes, not this case, so once again, not this case, but sometimes clearly you're involved with cases where smaller primary, one or two liver mets, more in that metacystectomy sort of. Does your discussion differ or decisions based on whether it's head or tail of the pancreas?
Yes, yes, with regards to timing, whether to do a combined procedure with pancreas and liver, and also the approach. I think a more straightforward scenario would be a tail lesion with one or two resectable liver mets, so that would be a good candidacy for combined resection by laparoscopy, obviously depending on the localization of the liver metastases. For head of the pancreas, it's a little bit different, but one or two is most likely limited territory of the liver, so could also be potentially candidate for combined resection. Otherwise, for head of the pancreas lesion, we tend to do liver first.
Okay.
Doesn't really matter as much for tails.
Okay, great, thank you. And so often our patients will go on and they'll have the discussion with surgery and whether they're curative, you know, clearly lots of these pancreatic neuroendocrine tumors go for curative intent. And what's the incidence of diabetes after? Because often they'll speak to the surgeon or endocrinology and they'll get a quote and then they always come back and say, they said this, do you agree with them? And we want to make sure we're saying the same thing that you're saying. So whether it's a distal pancreatectomy or Whipple's, endocrinology and surgery, what are you quoting as the risk of diabetes?
I think it really depends on the patient. If the patient is obese or have a family history of diabetes, it really increases the risk.
Yeah.
And I think for that kind of patient, for oncology surgery, they will accept the risk of increase of diabetes. And so sometimes we frequently see those patients after the surgery. So if they have diabetes, we try to manage first with medication, or sometimes we need to add the insulin. But I think they accept really easily the fact that they have diabetes because it's for an oncology surgery and for all the rest of the disease.
Okay. And whether they've had a Whipple's or distal pancreatectomy, is one more difficult to control, or no, it's other patient factors that come into play?
I think other patient factor really, it really depends of a patient factor.
Okay, okay, good, thank you. Okay, so then we go into our toolbox. We know we have lots of them, and I think this is going to be the challenge with pancreatic neuroendocrine tumors is what do we do first, second, third, or when PRT comes forward, especially in Ontario, many patients will already have that first, second, and third, and what's the best after that. So this is a sort of a list of things we can, the medical oncologist will start to think of and discuss with the patient. Certainly in this case, I was not comfortable with watch and wait, and I told the patient that, right? Lots of volume of disease, large pancreatic lesion, tumor thrombus, didn't even put that on the table. I discussed moving forward with somatostatin analogs versus chemo. He was a very intelligent gentleman, very thoughtful, and he opted for SSAs to start. Of course, if you're a bit nervous, then you frequently, I scanned him a bit more frequently in the beginning, saw him monthly just to make sure he's not bleeding anymore. His bleeding stopped. He's doing well. He's not going down. And so just a reminder that we do have data for SSAs. We have octreotide and we have lanreotide, and lanreotide definitely showed with the PNET group that this is the PNET group, that there was improvement in progression-free survival. So that's good. All right. So his first scan shows a heterogeneous response. Okay, so we see the primaries a bit smaller. We see a few liver lesions that are slightly bigger, so 2.4 centimeters to 3, 2 centimeters, 2.4, but he's still very well. Exam, he looks good. Blood work is all good. Should we do something different? And I think this is important with sort of helping patient predict what scans could show. And Danny Rayson often talks about this, where he warns patients, if we have millimeter changes, I'm not going to change treatment, because this can happen, as we know, right? With neuroendocrine tumors, we can initially see millimeter changes, and it's important that we watch for that. This patient is probably one of the higher risk ones for developing diabetes. From the endocrinology point of view, patients hate doing fasting blood work. Are you going to tell us you have to make them do fasting, or is random good enough for a high-risk patient?
I think I understand that patient ate a fasting blood work, so I think A1C could be a good thing to do maybe every 6 months and after, just to re-evaluate the risk of diabetes for that patient. Okay. And with the sample for the blood work, I usually do a random glucose too, but just not just the random glucose, I add the A1C too.
Okay, and you said about every 6 months?
Usually at the beginning, after I evaluate if the patient is not diabetes, maybe once a year, it's okay. It really depends of the patient. And if I see a random glucose that is high, after that, maybe I would do a fasting blood work.
Okay, okay, perfect, thank you. Okay, so first scan shows a heterogeneous response. We decide to continue the SSA at the same dose. After a year of treatment, this patient started to develop pancreatic exocrine insufficiency. My slides are very messed up. There we go. My apologies. So we have a number of products to use if they develop pancreatic exocrine insufficiency. So just a reminder to your patients, because this is a porcine product, so just remind some of your patients who happen to be Muslim or Jewish. Many patients are still okay with taking it, but just a gentle reminder for that. And can I see a show of hands when you're starting Creon? Who starts with 10 or who starts with 25? Who starts with 10? Okay. Who starts with 25? Okay. That's been my experience. I have started some patients at 10, and I feel I very rapidly have to go to 25. Okay, good. Yeah, you could give 2 tablets, yes. Of course, yeah. Okay, so my patient actually did have stable disease for close to 8 months, but then he started to have more rapid progression. His tail of the pancreas lesion is increasing, and between one scan and the other, we see multiple, in fact, almost all liver lesions increasing by at least a half a centimeter to a centimeter, every one of them. It wasn't a slow, steady progression. It was all of a sudden a change. The magic question is, okay, now I'm thinking about something else, but do I keep that SSA going, right? He's an asymptomatic patient. It's a question we don't have answered, but I think probably more people stop the SSA at that point, although we do recognize now with PRT treatment and their small bowel, Sten can confirm this, we usually keep it going, right, while they're on the PRT. So it's interesting now that we have pancreatic nets getting more access to PRT, do we keep it going after? So I think that's sort of an unknown question. All right, so what's my thoughts at this point? Well, we know that we hopefully are going to start to have the ESMO paper that Dr. Meinhardt just showed us, which is not this. This is bizarre. There it is. Okay, this is the mystery slides, but we'll keep going. So hopefully we'll soon have funding in Ontario and other provinces to do this. So I think these are some of the magical questions that are going to come up. So Sten, I know that before we had PRT netter, at tumor boards many times we would say, okay, let's do liver-directed therapy first until we've sort of exhausted that, and then PRT. Does that concern you? Is there any data, or do we need to start to report this? Is that the right thing to do? Is many embolization before PRT, or we just don't know?
So we don't know. And I think to harken back to that time, where really there was limited access for patients, it was really trying to find as many other alternative therapies as possible. Mm-hmm. And we're not in the same world anymore with improved access, specifically for small bowel. And so our discussion surrounding upfront PRT or PRT at progression versus other liver-directed treatments is really based upon the pattern of change, liver dominant versus other. Mm-hmm. Are we dealing with other sites of systemic disease which are either changing or becoming symptomatic? And so that's the main decision point about this. We still don't know the correct way to do this. Yep. And so, those discussions I think are nuanced in terms of which pattern we go. So I suspect it's going to be the same question for the PNETs, with the caveat again that the heterogeneity in the biology may be a little bit different for these ones that you're describing are changing rapidly. Mm-hmm. And so in that scenario, that might be one where, again, you look at other functional metabolic imaging at that time of progression, or potentially even rebiopsying to ensure that you are going down the correct pathway.
Exactly. Okay. So I was worried about the pace of the disease. I had no access to PRT. Everolimus, he's recently diabetic. Worried about the pace of the disease. Sorafenib, he's at risk of bleeding. Discussed rebiopsy, that's important discussion. Patient declined, and I started capecitabine and Temidol. He did some grade 2 elevation in ALT, so I dose reduced him. Endocrinology, when we give a lot of treatments, we start to see some liver changes. At that time, should we send back to you if he's on certain diabetes medications? Are there certain ones you're worried about if he is starting to see liver changes? Is there classes of drugs that we need to look out for and send back to you?
It's sure that we need to check the liver balance to make sure. At that time, I think we could continue all the medication. With the hepatic disease, the patient is at an increased rate of hypoglycemia with every class of medication. So we need to follow maybe more closely that patient. But for right now, I think we can continue the medication.
Yeah.
If patient have like a really hepatic insufficiency, we will hold many medications. The most secure medication may be the insulin, but for many patients, sometimes it's so to pass for medication to insulin is a really important treatment. So we have to discuss with the patient with the risk of hypo or to switch with insulin.
Okay, great. So the patient asked me, okay, we're going to start CAPE-10. Is there a marker you can tell me I'm going to respond very well with this? And a question to the med-oncs in the room, if a patient can't tolerate capecitabine, right, there's some rare cardiac vessel vasospasm, there's some rare hand-foot that you can't get any further. Would you continue just with Temidol alone? So that's kind of a question. So we all know this study very, very well, E2211. So just a reminder, MGMT, if it's present, can fix the methylation that is happening with Temidol, and we have a less response, and that's what's being shown here. We saw the PFS was positive. We saw that the overall survival was not positive, but probably clinically significant. And just a reminder, in my mind, I had to face this question once. My patient did not tolerate capecitabine. I continue with Temidol alone, knowing that the median survival was quite good at 53 months with Temidol alone. So sometimes it's a strategy you can use. And recently, Dr. Kuntz, who is the author of this paper, said, yes, MGMT shows increased response, but an association with PFS and OS, but it's not prime time yet. So just a reminder. Okay, and I think this is my last slide. So sequencing is important, is what I want to sort of end with, and we need to do more data, even real world data, and this is what Sten had mentioned already. And with this abstract, we need to know, and I'm sure they'll put it in the paper, how many cycles did these patients have? What was the distance between CAPE-10 and PRT? Do we need to consider limiting the number of cycles that we give a patient in a lifetime if we're considering PRT? I think these are all questions we need to ask ourselves with this increase in MDS for patients that receive CAPE-10 and PRT. So to be continued. Okay. So I hope that we reviewed, the basics of the PATH report, SSA, initially supportive care issues, PRT and pancreatic NET, some palliative techniques to help with symptoms, and sequencing challenging. I think it's going to be the next key factors. So thank you. Thanks to the panelists.
That was great, very, very thorough. So we're going a little late, but I think we should just do it. In case you're wondering what you have for lunch, it's called a Dr. Singh sandwich because he's on right before and right after. In all seriousness, I'm so thrilled to have Dr. Singh here. As many of you know, he's an international leader in neuroendocrine tumor treatment and really one of the founding people in Canada to help bring us up to speed. So, Simran, thank you.
Yeah, I was about to say I'm in the unpleasant position of standing between you and lunch, and I blame Dr. Goodwin for that. So I feel we should. She gets no lunch until everybody's eaten for going over time. So just get the slides up there. Cal must have a bad dad joke. I'm sure there's a bad dad joke going on, yeah. Or zebra. So as we get started, I guess I'll just quickly say we're going to just the two talks. The first talk is about clinical trial in NETs. The second is about guidelines. And after talking with Jackie and Enrico yesterday, we decided to merge the two talks. And so it's kind of like a part one and part two. So we'll do a bit before lunch talking about the principles of clinical trials, because I think it's a good time to review that. And then after lunch, we'll talk about what clinical trials are available in Canada. These are my disclosures. So, you know, it wasn't that long ago when we were told that it was impossible to do a randomized clinical trial in neuroendocrine cancers. And I think the last, over a decade now, the last 12 or 13 years has really showed that that's not true. And we've made some really incremental improvement within Canada, North America, and globally in the improvement in neuroendocrine clinical trials. Neuroendocrine clinical trials are certainly not easy. I think we all recognize, both due to the challenges with enrollment, to the heterogeneous nature of the disease, as well as the subgroups analysis that needs to be done and the stratification. They're very difficult trials to design, and I wouldn't hesitate to say one of the more difficult oncology trials to design. So we have made improvements in an incremental way as we've gone along. And this is just an idea of the landscape. This is by no means comprehensive, but there was this initial era when we had a couple of clinical trials in neuroendocrine cancer. These were very early trials, particularly not well designed. They were uncontrolled often. Toxicity was reported irregularly. The response was completely unstandardized or non-standardized. So, for example, if you look at the chemotherapy trial that was published in the New England Journal, the primary outcome was liver size by hand palpation. So you can imagine the bias that could be introduced there. There was little standardization of care. There were small trials. We didn't collect data about progression upon entry, and we know how important that is in neuroendocrine cancers to understand progression, to be able to, as a prognostic marker. And the idea of patient-reported outcomes or patient-centered outcomes were unheard of in this era. Now we can say, again, in this last little decade or so, we've moved into a new era of a new generation of clinical trials where we have a standardized assessment for response, which has been RESIST. That may or may not be a good thing. We can talk a little bit about that. There's challenges with RESIST criteria in neuroendocrine tumors. We've incorporated generally blinded central radiology review. We've been making incremental improvements in patient selection. We've come together as a community to coalesce around an endpoint of progression-free survival. That's been challenging at times, getting regulatory approval. In Ontario, it still remains challenging at times to get funding approval, but this is really the only realistic endpoint we have. I'm going to talk to you about a couple of other endpoints. And we've improved accrual, and we've done things like made sure that we assess things for like progressive disease on study entry. What we still don't have is overall survival benefit, and that can be challenging to talk outside the neuroendocrine community about the lack of overall survival benefit. We still, from our colleagues, face a lot of skepticism when we show these trials because they say, well, there's no overall survival benefit, and it takes a fair amount of detailed discussion. Many arms still remain single-arm studies with variable sample size and variable primary endpoints. That's probably due to necessity, but I think we need to start moving away from this, or at least standardizing this a little bit so that we can start working together a bit more globally to make sure that our data is incremental upon each other. So it is a real delicate balance when we're talking about how do we think about neuroendocrine trials. You know, we want to have accrual, we want to have a feasibility, which is obviously very important, but at the same time, we want to try to have homogeneous populations and not mix many different prognosis and many different types of neuroendocrine cancer. Someone said to me last week at Nanets that if you had asked somebody to do a trial in adenocarcinoma and you'd said put in a lung and a prostate and a colon cancer, nobody would take you seriously. But many people still think that we need to do a neuroendocrine trial, even though there's such a diverse population. So talking a little bit about endpoints, that's been a real challenge for us, often in getting drug funding, often in getting trials approved through cooperative groups. It's been a challenge here in Canada. We've had trials rejected because of the endpoint at CCTG, for example, although I think the culture is changing. So there's really two ways that patients can benefit from treatment. Either the treatment hopefully makes people live longer, the treatment might make the patients live better, or ideally both. So as I mentioned, the gold standard is overall survival, but it's not really a practical endpoint, I would say, in neuroendocrine neoplasms, partially because many people are going to have a long overall survival, which makes doing overall survival as a primary endpoint unfeasible from a resource point of view. But there's many different patterns that people may get. We have surgery, TACE, other trials, other treatments, and so when you add that to crossover, really it becomes very, very difficult. And I think this has been demonstrated when we see even the NETTER-1 trial, which had a hazard ratio of 0.21. And what I tell the residents is, if this was a breast cancer trial with a hazard ratio of 0.21, it would be on the front page of the New York Times, it would be all over every network, it would be groundbreaking, and we would be having discussions about all this. And in reality, although it was a New England Journal paper, even that paper didn't have an overall survival advantage due to post-progression heterogeneity of treatment. So I think, again, we have to move beyond this idea. And this is, I don't need to convert the room on this idea, but I think what we do need to do is continue to have these discussions outside this room with funders, with stakeholders, and unfortunately with our colleagues as well. So there's also a new I think we've made some advances in patient-centered outcomes. We have the general pros that are often included, EORTC, QLC30, FACT-G, but we are making improvement in specific neuroendocrine patient-reported outcomes. The GI-NET 21 was the first one, has its limitations, and I think if you've worked with it, you have some frustrations, but there are new ones coming up. I worked with a team in Chicago, and we did this one, the FACT. There's a series of them now. And these were pros that were developed with actual patient qualitative interviews, talking to patients who had the disease, trying to understand what symptoms they had, what affected their quality of life, and developing that. So hopefully that will continue to be used. And we've started to really include health-related quality of life in studies. It's not uniform yet, and we continue to have challenges, even in the trials I'll show you today, sometimes from regulatory authorities to include quality of life, which I think is really changed. I think we need to all work together to ensure that as trials are done, it's mandatory that quality of life be included as a secondary endpoint, even in randomized phase 2s, which isn't traditionally done. The reason for this is sometimes in neuroendocrine cancers, randomized phase 2s are definitive studies, and we need to make sure that we include quality of life in that. And we have seen differences in the PROMED trial, in NETTER-1, in the post-hoc analysis of the TELESTAR study. We have seen meaningful impact in quality of life with patients. So again, I mentioned PFS is our standard endpoint. It's used in our pivotal studies. Its advantages, it's appropriate for both cytotoxic and cytostatic agents, and we know many of our agents are cytostatic, and it's not impacted by subsequent treatment. So we know that at least we have an endpoint that we can measure. At the NC's Eyes clinical trial planning meeting, this was published in JCO from 2011, this brought together a number of leaders from globally to sort of chart the path of neuroendocrine tumors. Some of the major principles that they advocated for were to avoid mixing tumor sites if possible, to try to have a more homogeneous population. But they also recommended at this point that our trials should be designed with PFS as an endpoint, and that's sort of what's been done. There has been a meta-analysis done in 2018 showing that most of them reported PFS as an endpoint. We haven't been able to show that correlation. Calvin Law and myself, when we first started our clinic, tried to do this and weren't able to show a correlation between PFS and overall survival. We're starting to see some signs of it, and maybe over time we will actually get enough power between all the different studies that are done to be able to show correlation between PFS and overall survival. And right now we're starting that probably in the somatostatin analogs is where we're going to start to see it. So hopefully, much like in colon cancer, where 5-year overall survival, 3-year disease-free survival became a very accepted surrogate endpoint, due to the work by Dan Sargent and others, that will also be the case in neuroendocrine very soon. So some of the challenges we have when we're thinking about trial design in neuroendocrine cancer is how do we assess response? I won't go through this in detail because I know we're all hungry, but I think we can all assess to the fact that RECIST criteria has challenges. I think Rachel was just mentioning, and Danny has also talked about this, about, you know, slow progression. What does that mean if it doesn't meet RECIST criteria? What about, how do you bring in biochemistry in that, or patient symptomatology? Partially explains why we sometimes have discrepancy between on clinical trials between central review and local review. Local review takes into account sometimes the other factors that are surrounding the patient, whereas the central review simply looks at the RECIST criteria. That being said, we don't have a great option at this point. There's been a lot of talk about whether like just something like the CHOI criteria could be used. We have tried ourselves at Sunnybrook to sort of look at some of this density-based criteria. Haven't really been able to find that magic potion yet. I think there, you know, it's still a work in progress. I think there's many centers looking at this. Hopefully we'll get a bit more of a composite endpoint moving forward. Right now, though, we don't really have a good model. One thing that is sort of promising that I think people should be aware of is tumor growth rate, and this may have promise moving forward. So the tumor growth rate is really looking at pretreatment tumor growth versus tumor growth at 3 months, and it looks at the change in volume and the slope and the rate in the change in tumor volume. So prognostically, it does predict RECIST-based PFS, and we've seen that in numerous retrospective series now. Predictively, at least in the Clarinet study and in the SpinNet study, I should update this, we just presented the SpinNet study data last week at NANETS showing the same thing. The tumor growth rate actually was a good predictive marker as well. So these are all post hoc analysis, though, and I think moving forward, we need to start including these in trials prospectively, and some of the new radioisotope trials are in fact including this as a secondary endpoint. So hopefully this may be a new promising endpoint as well. When we look at how we assess response to PRT, I think we've heard a little bit. We have a number of experts in here, so I don't really need to talk too much about this. I think there's still probably better ways that we can assess response to radioisotope therapy. It certainly continues. RECIST criteria, I don't think, is probably the ideal way of measuring this. However, at this point, it's still controversial about SUV change after PRT, what that really means. Certainly looks impressive sometimes on imaging, and presentations look great, but we don't yet know if that really impacts the patient outcome. So that's another area that I think we really need to work together on. I know people hate blinded assessment, and we've certainly had our challenges with this, but you know, if you look at trials such as the RADIANT-2 trial, the difference between local assessment and blinded assessment and people coming off the trial locally, we're actually starting to see this a little bit in NETTER-2 as well. People coming off the trial before central assessment, it can actually have very detrimental effects to the trial because you lose your power, but it's an intention to treat trial where you still have to include the patient in the statistics. So although it adds cost and complexity, I think it is important. We do see a fair amount of discordance, and again, we have to have, if we're going to do these trials, we have to use these measured standardized outputs to move forward. And it reduces bias. So I would still advocate that for now we need to still include central review in our trials. So the last thing I'll say before maybe we take a break is I think this idea about us needing new trial designs. You know, we're finding more and more that the landscape in terms of clinical trials is thinning. Clinical trials have become much more expensive to do, and we need to be able to make sure the resources we have are used judiciously and used well. We are competing in many cases when we try to propose a neuroendocrine trial with breast cancer, colon cancer, prostate cancer, and this is the same pot of money. We've had examples, for example, of lenvatinib, a very promising drug in a phase 2 trial. The TALENT trial showed the highest response rate of any targeted agent. The pharmaceutical company unfortunately just decided that they weren't going to pursue it despite a positive outcome. And you know, although we do have access to it on compassionate use in Canada, it's not going to be a registrational drug. And that really is disappointing, and that's really due to a lack of resources that we're not going to have access uniformly to a very effective treatment. So again, it provides more effective and efficient drug development. I think we need to start thinking about things like I-SPY trials and, you know, rotating tumor trials, there are new trial designs that are coming forward. We need to make sure that we use our biomarker data that we have. We try to do predictive biomarkers, integrate them into the trials as much as possible, and really get to this point of personalized medicine in neuroendocrine cancer. So again, I think these are incremental changes. We've come a long way if you think about how the trials have come along, but we still have ways to move to make more effective trial development in neuroendocrine cancers. So maybe I'll stop there, see if there's any questions, and then maybe after lunch we can actually go through the clinical trials and the new guidelines in the Canadian context. Rachel?
Simran, in that
Although I don't know, after keeping us late, you should be allowed to ask a question.
I did, anyways, I started late. So did they like the design that we see often where if you include multiple tumor types in a study, you cohort them? Do you know what I mean? Like,
Well, yes. I mean, I think if you're looking at a single arm,
Yeah.
trial, then it makes sense. If you're going to randomize, you have to, you can stratify, of course.
Yeah,
But I do think, I think that it comes back to that trial I was saying about reasonability. So like mostly now, most of our trials would combine, midgut and pancreatic tumors together, and most of them would stratify for midgut and pancreas. It would be unlikely today that we would do a trial that would include, for example, bronchial nets along with midgut, along with pancreas. That would probably be unlikely. So again, maybe, and we're moving forward, we see pancreas-only trials as well. The lung-only trials are really struggling. The only lung, we had Radiant-4, which included, as you said, a lung cohort. But the SpinNet trial, unfortunately, didn't complete enrollment, had to be stopped. And as I'm going to show you, the second dedicated bronchial net trial, which is PRT versus everolimus, is struggling. It's very early, but it is struggling. So, yeah. Sten?
So you talked about the rotating trial design, which I think is interesting. It's something that we've started doing in glioblastoma. So the Agile study is doing exactly that, which is really rapid trial or rapid agents being put into this design. The hard part for that, again, and this leads to everything, is the variability of these disease and how you would determine what a standard of care would be. Would you have a rotating design for lung, pancreas, and small bowel, and how feasible would that
So
be?
it's actually not so much that. The challenge that we have with things like iSpy, rotating trial designs in neuroendocrine, is for those trials to be effective, the idea is you quickly assess response, and then if it's positive, you move forward into the next level, and if it's not, you rotate out and move something else in. We don't often see quick responses, so that makes it very difficult. So what we do need to see is we need surrogate markers. So for example, like in acromegaly, you can see IGF-1 levels drop, and I always say I'm really jealous because many of the somatostatin analogs we see have been developed in acromegaly, but they have a biomarker. So I think the key for us to be able to do that is to develop either a pathological or a serum biomarker where we can see quick responses, even if it's a surrogate, and then we can move forward. That sometimes can be challenging, and what may be useful for us is, with the surgeons, is like these window of opportunity trials where you try a treatment and then you use that window of opportunity before surgery to do something along that lines, to do a quick assessment, and then you do surgery, and then you have the pathological response. So like they're talking about like SSTR2 up regulation of receptors, so stuff like that, like HDAC inhibition, try to increase SSTR2. I think that might hold some promise, and maybe we'll get to the point where we can do that, because I think you're right. For neuroendocrine, it would be ideal if we could do these kind of trials, because we don't have a lot of patients. It's hard to accrue patients on these trials, so it would be good if we could sort of filter out and really concentrate our efforts on the agents we want. Yeah. Okay, I think we're going to wrap it up there and off to lunch. What?
No one's allowed to eat until they have
Oh,
a photo taken.
picture first. Yes, sorry, yes.
Sort of like when you line up for jail before.
Yeah.
Everybody, please. Yeah.
Okay, guys, can we come up to the front? Who's ever last doesn't get lunch. Okay, that still didn't trigger anything. Come on. Let's go. Yeah, you should probably, Rach, you should cover it.
Hello, ça va?
Go in front of the table. Just sit. You should be wide enough.
Rico, you come in now. Yes. No, no, I give camera to somebody else. I'm good. No, you're not good.
Listen to the doctor.
Okay, so check this.
Could one of you volunteer to take his camera, please? Rico, give your camera.
Almost everybody this side of the functional visit weddings and bar mitzvahs, but only on weekends.
enseñan nada